I have started my recording. You can go ahead.
Okay.
Yeah, we are live on YouTube now.
Just wait few seconds. Setting up. Yes, sir, we are live, sir. Manish, sir, we are live on YouTube, sir.
Good evening, everyone, and I welcome you all for the 6th webinar of Delhi Orthopaedic Association. The topic for today is unstable pelvic fracture, resuscitation to rehabilitation. And we have a very esteemed faculty from India and abroad. And I welcome Dr. Vijay Sharma. I will welcome Dr. Kong from Singapore. I welcome Dr. Inder Gill. He will be joining us. I welcome Dr. Vivek Trikha, Dr. Abhay Allens, Dr. Puneet Mishra, Dr. Amit Gupta, and Dr. Shivanand. So with this, we start today, and I request Dr. Sharad Agarwal, our Delhi Orthopaedic Association President, to come and start the proceedings and say a few words.
Thanks, Dr. Manish. Dear friends, good evening. I welcome you all to this next in series of webinars being conducted by Delhi Orthopaedic Association. In today's webinar, Dr. Vijay Sharma and his learned colleagues shall trace the journey of a case of unstable fracture pelvis from ER to his recovery. This condition is one of the real orthopedic emergencies which orthopedicians face some or other time. I'm sure by the end of this program, we all shall be much wiser how to better handle these difficult situations. Now I request Dr. Vijay Sharma to start the proceedings. Dr. Vijay Sharma, please.
Good evening, dear friends. Good evening, dear friends. I'm Dr. Vijay Sharma. I'm Professor of Orthopaedics in Trauma Center, AIMS. I welcome all the speakers and panelists to this webinar on unstable pelvic fractures. I'm so pleased to have this opportunity to introduce our distinguished speakers and panelists. So I think I need to. Can you see now?
You have to share your screen.
I have already shared.
It's not visible. First minimize your zoom, then share it.
Okay, yeah.
Yeah.
Yes, sir. Can you see now, sir?
Okay, so first of all, our moderator for the session is the senior consultant Gangarambo, and he's president of Indian Orthopaedic Association. So this is basically the whole of the work is done by Dr. and his team. So I would like to welcome and introduce the international faculty, Dr. Kok Sung Kong. He is into practice now, and he's in Farrer Hospital and Mount Elizabeth Hospital. He is regional and he will be joining soon. And he is in Royal Salford Hospital, which is a major trauma center attached to Manchester University Hospital, which is a teaching hospital in Midlands. And his major interest is in lower limb arthroplasty, revisions, and complex acetabular pelvic trauma. So now Dr. Our friend, and he is professor and head of the Department of Orthopaedics in AIMS Jodhpur, and he is again faculty for AO in various courses. Dr. Puneet Mishra, he is again a professor, but now he has shifted to practice. Now he is senior consultant in Fortis Shalimar Bagh. Earlier he was attached with UCMS and GTB hospitals as a senior professor. Then the rest of the four we Association ISTEC. He's one of the members, founder members there, Indian Society of Trauma and Acute Care. Dr. Shivanand, I welcome you. Dr. Shivanand Gamanagati is Professor Radio Diagnosis. His keen interest is in hepatobiliary intervention and obviously musculoskeletal intervention radiology. Dr. Vivek Trikha, my friend, my brother, he's again a senior professor. We work together, and he's again faculty for, he's chairman of AO pelvic courses, and he is faculty for almost all AO courses. Welcome, Dr. Vivek. Now, panelists or present president, past president, and future presidents, I welcome all of you. As a panelist, and then our dynamic Dr. Sharon is our dynamic secretary, Delhi Orthopaedic Association. I welcome Dr. Harmesh Kapoor is vice president, and Dr. Vineet and Dr. Rehanul Haq, they are the teaching coordinators of Delhi Orthopaedic Association. And obviously, this webinar is not possible without the help of these three young dynamic orthopedic surgeons, Dr. Ashok, Dr. Shamshul, and Dr. Ravi Chauhan. So with this introduction, we start with the case scenario. And obviously, this is a young patient, and patient comes to emergency department, run over by car. We get almost daily, we get such scenarios. So we are going to discuss this unstable case, how we treat the patient in initial phase, and when the patient becomes stable, how to do definitive management. So 2 hours after the injury, patient reaches trauma center.
Please share your screen.
But I'm audible.
I would start.
Okay, now Amit will start because the same case is with the Amit. So airway is clear, breathing is spontaneous with the respiratory rate 18, SpO2 100, CCT negative. Circulation, patient is tachycardic and hypotensive, and PCT is positive. So basically, what exactly Dr. Amit is going to tell us in next 10 minutes is ED management, what kind of fluids, blood, what is massive transfusion protocol, how much fluid, any other ED. Over to Dr. Amit.
Thank you very much, Dr. Am I audible?
Yes, sir, clearly
yes,
audible.
you are audible. Yes.
You can go ahead, sir.
Okay, so thank you so much, Dr. Vijay, and I must thank the Delhi Orthopaedic Association President Dr. Sharad, and also Dr. Manish for having given us given me the opportunity to talk on a very important aspect of unstable pelvic fractures. Now, obviously, pelvic fractures are a very, very important aspect of blunt trauma, especially road traffic injuries, where there is a lot of energy transfer between the event and the external forces. And we'll be discussing the ED management initially of an 18-year-old male who was again run over by a car, and he reached the trauma center or our hospital in about 2 hours of getting injured. Now, as it is done, normally we would actually triage each and every patient into a red, a yellow, or a green triage tag. And very simply, if I put it, the red area patients, anybody who's unconscious, has a compromised ABCD, which is the life support system of the body, or having any major injury with dangerous mechanism of injury, is triaged initially as red so that he undergoes a full ATLS paradigm of initial management. Anybody with a stable ABCD, but with a major injury warranting admission, is triaged to the yellow area, and the rest, walking wounded, minor injuries, are generally triaged to the green area. Well, this particular patient was triaged to the red area because he had definite dangerous mechanism of injury. Now, the initial assessment management paradigm is a rapid assessment of patient's physiology first, which we often undermine or forget. So it is just a reminder for all our orthopedic colleagues that whatever be the mechanism or whatever be the status of the patient right now, if the mechanism is dangerous, you need to see the physiology first, and then only then go on to see the anatomy of the injury in a prioritized manner. Simultaneously, we do resuscitation. Now, the purpose of initial assessment and management of these patients is identification of immediate life-threatening injuries and their management right there, because there are certain injuries which would take away the life of a person without actually even giving you any warning. And anatomy is not a very good indicator of the quantum of problem with the physiology which is happening. So the priorities remain the same as in the ATLS paradigm. You begin with the primary survey, which is nothing but a quick assessment of the A, B, C, D, E. Then resuscitate simultaneously. You can use some adjuncts like monitoring of the patient, certain imaging adjuncts, but not short of quick physical examination is must for the primary survey. You keep on reevaluating these patients because these patients are very dynamic and can change their hemodynamic status very fast. Once you're sure that the reevaluation has been done and the patient is getting stabilized, only then you move on to knowing the actual injuries of the patient, which is done in a detailed secondary survey. You can this time use adjuncts such as CT scan or special studies, which are adjuncts to secondary survey. Keep on reevaluating the patient till the time the patient can be transferred to definitive care. Remember that there might be certain instances where you might have to transfer to the OR right after the primary survey if the primary survey is not getting stabilized. And we would focus in this particular case on the primary survey and what we do normally while resuscitating the patient in the emergency department. Well, primary survey is nothing but a quick assessment of the airway, taking control of the cervical spine, maintaining the breathing and proper ventilation. That means oxygenation and CO2 level should be proper. C comes circulation with hemorrhage control. Then quickly assess the disability, which is brief neurological assessment of the patient, and then taking care that the patient does not land up in hypothermia. Now, in pelvic fractures, the C is a big problem. So although C is a big problem in pelvic fractures, but because the patient has undergone a considerable injury, we obviously have to look at the airway and the breathing first, because the instability of the patient might be due to the airway problem, breathing, and only then we come on to the circulatory problem. So in our patient, the airway was patent, the breathing was spontaneous, slightly increased respiratory rate, the SpO2 was fine, the chest compression test was negative, indicating that probably he did not have any injury to the chest. But the problem here again was the C. So he had a heart rate of 144 with a blood pressure of 84/54. That means he was hypotensive. There was a pelvic compression test which was positive. Disability, again, GCS was fine. He was normothermic. Therefore, the standing out problem here, which you can all see, that he is in definite shock. This patient is in shock, and in trauma, we always consider hemorrhagic shock until and unless proven otherwise. So this particular patient, the primary ED resuscitation would hinge upon, obviously after the A and Bs are taken care of, on fluid management. And what the mantra nowadays for fluid management is balanced resuscitation. That means do not over resuscitate with crystalloids, maintain the fluid balance along with the blood and blood products. So first of all, put in 2 large IV peripheral lines. They should be short and they should be wide. So generally we would put in sort of 16 gauge or 14 gauge in the antecubital veins. Secondly, there's a lot of debate going on between whether to use colloids or crystalloids, but crystalloids win hands down, and there is a significant scientific evidence now that the crystalloids are the way to go, at least in the resuscitation of a hypotensive patient. So either Ringer's lactate or normal saline. How much fluid to give? So the latest ATLS guidelines say initially you give a bolus of 1 liter of crystalloid, call for blood. That means as soon as you put the peripheral lines, take out some samples and send for a grouping and cross matching and order blood as soon as possible. But then if the blood does not arrive, don't leave it at 1 liter only. You can give boluses of 1 liter and keep on resuscitating the patient. But obviously you have to call in for the transfusion, initially beginning with PRBCs, but massive transfusion protocols across the world have hinged around the ratio of 1:1, which is PRBC, FFP, and then later on, maybe if he's really bleeding too much, then also platelets. Can we use other hemostatic agents? Yes, the CRASH-2 trial has very clearly said that if the patient arrives within 3 hours of the initial injury or bleeding, you could give 1 gram loading dose of tranexamic acid, which is a very cheap hemostatic agent, over 10 minutes, which is then followed by infusion of 1 gram over the next 8 hours. And there have been significant improvements in mortalities due to hemorrhage by using this simple agent. Adjuncts to primary survey. Well, as I said, you have to examine the patient fully. That means you have to examine the site of bleeding, because a hypotensive patient has already lost about 1.5 to 2 liters of blood. You have to find out the possible sites of bleeding, which are either external, the chest cavity, the abdomen, the pelvis, and retroperitoneum, which is our concern right now in this particular case, and then long bones. You do a pelvic compression test, which is done as it is very well shown, and I need not tell the orthopedicians how to do a pelvic compression test. But again, once again to reiterate, should be done only once to avoid any pelvic sort of movement, undue movements. Adjuncts, imaging adjuncts include the focused assessment by sonography in trauma, which is fast exam, which is just to see the presence of fluid either in the pericardial cavity or the abdomen, the 3 quadrants in the abdomen, because it will tell us the approach. If the patient remains unstable, we need to open the belly along with the retroperitoneum also, the pelvic retroperitoneum. And if the FAST is negative, then probably we can do away with the laparotomy, and then we can actually pack extraperitoneally. So FAST is important in pelvic fractures. You need to do a chest X-ray and a pelvis X-ray also. Our patient had this chest X-ray. There was no rib fracture, no hemopneumothorax. There was essentially SpO2 was fine, so we would be okay. And then the pelvics. This is the pelvic fracture. You all know this denotes a very unstable fracture, and these are the clips which were applied due to pelvic binder. So the last thing which you need to do is apply some sort of a hemostatic thing in the ED for an unstable pelvic fracture, which is a pelvic binder. A pelvic binder should be applied as soon as possible. We all know how to do it. It should be at the level of the trochanter. So the trochanter should be made centric. This reduces the pelvic volume and also decreases the hemorrhage sites by stabilizing the pelvis. I think I'll stop here because I'll stop sharing the and probably
Thank you, Amit.
I think yeah, Dr. Vijay.
Okay, thank you, Amit. I think any questions by the panel? In the meantime, I think this patient is still unstable even after fluids and binder. Dr. Sharad, any question from the panel?
Dr. Amit, excellent presentation. I just want to clarify this pelvic binder. Will you apply after the X-ray of pelvis, or even on clinical basis you can apply initially the patient is unstable?
So we do it, sir, on clinical basis itself. We do not wait for any X-rays for a pelvic binder because it might be too late by the time probably an X-ray, even a portable X-ray is done in the ED. We don't want to lose those essential 5 minutes or 3 minutes also. So we would apply a pelvic binder. After all, it would not do any harm, even if we have a stable fracture on hand.
There is lot of posterior instability. In that case also it will help us?
Yes, sir, it does. It does help. And I think later on, probably Dr. Vivek or Dr. I think somebody would talk about how a pelvic binder, because it's a circumferential binder. It is not just, compressing it anteriorly. So it would help even in the cases of posterior instability.
Thank you.
Any other questions?
Dr. Amit. Dr. Amit.
Yep.
Hello.
Yeah, Dr. Vineet, yes.
Dr. Amit, hi. Dr. Vineet here. Dr. Amit, for the sake of students, most of our hospitals which are working in the peripheral level, where we are getting many of the RTA patients, the polytrauma and all that, and there we don't get this proper pelvic binder, and maybe in the night time when we are getting this patient. So what do you give message to all the residents how they should manage immediately in that place?
Yes, sir. If you would have seen my photograph also, there was no pelvic binder which was there. It was just a sheet which is easily available anywhere, or a OPT or a operating towel or whatever sheet you can get. The message remains that it should be circumferential, should be at the level of the trochanter, and it should be firm. So you can use a knot also, but generally, sort of towel clips are the best, so that you can ease off the pressure once in a while. So you can use a normal, bed sheet. We normally use bed sheets. We also don't have any commercially available pelvic binders, even at AIMS. So it's a very good way of doing it, where resources are not that much to have a pelvic binder.
Thank you very much.
Okay. Thank you, Dr. Amit. I think the patient is still unstable. Patient is still tachycardic and hypotensive. So what exactly is the role of external fixators? So Dr. Puneet is going to tell us about that. Over to Dr. Puneet.
Okay,
Start sharing your screen.
audible? Yeah. Am I audible?
Yes, yes.
Okay. So now we have a patient who's actually bleeding from the pelvis or from the other vital organs that we have to find out. So what is the role of external fixation? And by talk, we'll also cover the role of pelvic binder as we will proceed forward with the talk. So an unstable pelvic fracture patient who is sometimes in a polytrauma scenario, in almost 25% of the patients, more than 80% of the chances are that the bleeding from the pelvis, if it is there, is from the cancellous bones. And in only 3 to 10% of the cases, the bleeding would be arterial. And in the rest of the 40% of the cases, we have to look for the bleeding from the other sides, to which our primary survey will help us find out that. The lifeline of management of all such patients is early diagnosis along with simultaneous control of hemorrhage. So pelvic ring is actually a ring which is stabilized, which offers 60% stability from the posterior complex and only 40% stability anteriorly. So it's a suspension-like bridge. And in the pelvic floor, the sacrospinous, sacrotuberous, and the sacroiliac ligaments, they provide rotational stability, as well as the fascial attachments. They help bind the pelvic floor and allow the tamponade to be there. So this loss of tamponade allows the hemorrhage to control in an unstable, allow the hemorrhage to collect in the unstable pelvic fracture scenario, to which a pelvic binder or external pelvic fixation comes to the rescue, wherein once the bleeding cancellous surfaces are opposed, the bleeding is supposed to stop if it is arising out from the cancellous bone or the venous plexuses. So as where Dr. Amit left, the patient has already received an initial fluid resuscitation of around 1 to 2 liters of crystalloid. His primary surveys has already been done at the same time, like a fast chest X-ray or a pelvic X-ray. And not to underscore the value of clinical examination like a scrotal hematoma or a bruise around the gluteal region, bruise around the anterior abdominal wall, a severe deformity of the entire lower limb, these in itself would suggest that the patient is having an unstable pelvic fracture even without having to do a pelvic compression test. So that is what the pelvic binder would be, by using a readily available sheet which has to be circumscribed around the trochanters and the pelvic region of the patient, and at the same time the legs have to be bound together with the knees flexed and the lower limbs internally rotated. So external pelvic stabilization has a vital role in resuscitation, and the immediate application of a pelvic circumferential compression device like a commercially available binder or even a readily available sheet in the emergency department should be applied in all cases of a suspected pelvic fracture, and that is while you are examining the patient. That should come upon to the patient within the first 5 minutes. That's most beneficial in rotationally unstable fractures, but it doesn't even harm even if the patient has a lateral compression injury. You just have to use your force normally, you don't have to overcompress them. So that's the technique which has been shown here. You pass a sheet around the levels of the pelvis and the greater trochanters, then you fold from the one side to the other side as has been shown in figure 2, then from the opposite side, and then you apply clamps here. And once you have applied the clamps there, apply constant force on both the arms of the sheet, and then extra force you can apply arterial clamps or a sponge holder forceps or longitudinally. So that will give you a circumferential compression, and even this will be effective even in posterior complex injuries or vertically unstable fractures also. At the same time, one has to remember that the sheet has to be at the level of pelvis and the greater trochanter and not above or below. You have to flex and internally rotate and tie the legs together for this to be effective, and that will effectively reduce the pelvic volume. we should also be aware that this cannot be left beyond 24 to 36 hours because that will cause skin pressure ulceration and will not be able to monitor the skin around the pelvis. Moreover, if the patient needs an access for laparotomy or a further pelvic packing, this will be an hindrance. So if we look at the algorithm where we are, we have to stop the hemorrhage, and the hemorrhage control revolves around pelvic containment, laparotomy, angiography, and pelvic packing, depending on what the patient's presentation is and what the findings are. So if a patient is there who has an unstable pelvic fracture with the persistent hemodynamic instability despite initial resuscitation, so he is not a responder. So he's likely to be either a transient responder or a non-responder. So if the patient is a responder, then he goes for definitely pelvic management and CT scans, inlet and outlet and other studies. But if he's a transient responder or a non-responder, and the past examination shows that there is another injury also, so the patient is likely to land up with a laparotomy. And in that case, the pelvic external fixation would be required to replace the pelvic binder, and the patient also may require a pelvic packing if he continues to bleed inside the pelvis. Or if it is a transient responder and the patient gives you time for getting a CT scan done, and you see that angiography is possible in your setup, then probably an angioembolization will work. If you see that the bleeding is not, if bleeding is not controlled by a pelvic binder and the patient continues to bleed in the absence of any, in the absence of past being positive, so that means probably the patient is bleeding from a major arterial vessels. And in case the angiography is not possible timely, the patient is still a candidate for open pelvic fixation and at the same time supplemental pelvic fracture fixation with an external fixator frame. So coming on the fracture morphology, open book injuries where the patient continues to be hemodynamically unstable or in a polytrauma scenario or in association with a significant peripelvic soft tissue injury, you will need a fixator for emergent as well as early control of bleeding to save the life of the patient, and especially so if the patient also has a vertically unstable and a rotationally unstable pelvis. So this classification will be covered by Dr. Abhay in the future talks, but just to highlight the point that externally pelvic injuries which are which are unstable rotationally as well as vertically, and APC type 3 injuries, they are the injuries which are almost always associated with significant amount of hemorrhage, and more often than not, these injuries will actually require a replacement in case the patient continues to bleed despite application of a pelvic binder injuries. For management purposes, APC3 and vertical shear injuries, they behave in a similar way. So the most important indication for an external pelvic fixation frame is resuscitative to stop the bleeding. So a transient responder or a non-responder with a severe pelvic bony disruption as seen on a pelvic X-ray like an open book or a vertical shear or a APC type 3 injury would require a pelvic fixator to stop the bleeding or to control the bleeding, or despite it being an unstable pelvic fracture in a polytrauma scenario where the patient continues to be hemodynamically unstable, probably due to another bleeding from a solid organ injury. This is the patient who is fast positive and may require a future laparotomy. So this patient also will be a candidate where before the laparotomy you will need to do an exchange external fixator. And a third scenario can be a patient where there is a unstable pelvic fracture with severe concomitant soft tissue injury like an open pelvic fracture. Again, this patient will be better managed by transferring to an external fixator from a pelvic binder just after the initial stages of management, because that will lead to better nursing and better tissue management of this patient. So in all these scenarios, you have to replace the binder with an external fixator, preferably in an OR. The crux is that this has to be done as an emergency procedure before the laparotomy, and the frame application should be quick, which is the bottom line, and the frame application should be simple so that you can do it finish within a few minutes. Don't take too much of a time. So the iliac route and the supraestabular routes are the two commonly used routes, of which the iliac route is one of the most easy because most of the residents and doctors are trained to do that. So another scenario could be where you want to stop the bleeding immediately is a fast negative patient who is a transient responder or a non-responder even after frame application. So this is the patient who is likely to be continuing to bleed from the pelvic fracture, and possibly more often than not would be a patient who's bleeding from the major artery. So this patient would probably require as a next step as a pelvic packing on angioembolization, depending on your setup and on your availability of angioembolization facility. So if you think that the patient is going to, you plan to do an open pelvic packing, again, then you will have to apply a concomitant external fixator, and you have to, and in case a timely angioembolization is available, then this can also be done with a circumferential pelvic compression device like a pelvic binder. And the rare indication or an uncommon indication, I would say that role of external pelvic fixation would be as an adjunct to definitive posterior internal fixation, where the anterior part of the injury can be stabilized with an anterior frame. Sometimes the anterior frame can be definitive treatment also in certain open book injuries, APC1 or to APC3 injuries, LC1 to LC3 injuries, depending on fracture morphologies. It can be a definitive treatment depending on a case-to-case basis. And in certain cases where the patient has a severe posterior soft tissue disruption, anterior frame along with traction can sometimes serve as a definitive way of fixation, where you will have to accept a certain degree of malunion. So coming to the ladder of pelvic fracture stabilization, it starts from a pelvic binder and runs through invasive, and various routes are the high route, the low route, and various types of clamps which are available. So the commonly we apply as which are used is the anterior type 1 external fixator, where the high route is the iliac crest fixator. The low route utilizes the supraestabular pins or pedicle screws. Also, when you use a pedicle screw, it's commonly now popularly known as infix. We'll just see that. And as the ladder progresses, you can choose for internal fixation or a combination of thereof. Biomechanics, obviously, you have to keep in mind regarding the positioning of the pin, the frame design, the location, and etc. So coming to the types of the most common route and which can be done very quickly in the OR is the iliac route. The other common route is the supraestabular route, where you target the bone around the anterior inferior iliac spine and target the sciatic buttress. So that can be a supraestabular external fixator when you use Schanz pins, long pins, or you can use a pedicle screw when it is known as an internal external fixator. When there is a posterior injury along with sacroiliac joint disruption or posterior instability, you can use an iliosacral posterior C clamp, or you can use an anterior C clamp when the same clamp is put to use from the supraestabular region. One can also use a trochanteric C clamp in dire circumstances, where each of the trochanters can be used for application of pins of the C clamp just for brief control of hemorrhage or immediate control of hemorrhage using the C clamp as a life-saving measure. So open book injuries with posterior ligaments where the hinge is intact, all designs will work. The problem comes in when you have a type C injury, where only a C clamp is supposed to be the ideal solution, so as to say, to control acute hemorrhage. So no designs with the anterior frame will work well, but frames which use the anterior inferior iliac spines, they are supposed to be biomechanically more better than the ASIS frames. But as a bottom line, if we always remember, whenever we need to do resuscitation frame, anterior frames will provide adequate stability to control the pelvic volume. So you can tide over the acute resuscitation phase by doing an anterior frame, even if there is a posterior injury, by obviously giving traction, flexion, and internally rotating the limb while application of the frame. So coming to a common method of application of the iliac crest fixator, we have to be aware that in an emergency scenario, 2 pins on either side of the pelvis are actually enough. The rod should be such so that you do not actually obviate, preclude the future laparotomy procedure. You have to be aware certain anatomical facts, like iliac crest is almost in a normal pelvis is tilted 45 degrees towards the operating table, which will be tilted more in case of an open book injury. There is a lateral medial slant of the iliac wings, and this slant can be exaggerated in an external rotated pelvis. Also, pins would not be aligning one behind the other because there is a curvature in the crest, and the entry point to target the dense bone would be between the medial third and the half of the iliac crest. To avoid pitfalls, it is better than in the initial stages of application, you can use 2 K wires as a guides to your inner and outer cortices, and then you try to hit the exact entry point and spare a gap of around 1 to 2.5 centimeters behind the anterior pin, so as to you can counteract. Another important technical tip here you can take home is that if you have to use in an unstable pelvic situation, you can always use a small incision perpendicular to the crest, because once you close the pelvis, so you'll have the pin will if you do not use a perpendicular incision, the skin will start to impinge onto the pins, and that will lead to future infection and crest formation. So you can use a small incision perpendicular to the crest, so that when you close the pelvis, your pins can be easily do that. The maneuver can be easily done. Quite frequent errors like vertical pin insertions, and you should always, when you're using an anterior frame for a posterior injury, flex and internally rotate and apply traction while tightening the connecting rods. Supraestabular external fixator is the low route, where you use the bone around the anterior inferior iliac spine for the entry point. It's increasingly being used as an adjunct to definitive fixator. definitive fixation, and you have to target the teardrop which is in front of the which is in the supraacetabular bone. And how do you get to know that teardrop is by taking an operator outlet view while applying the fixator. So one pin on either side and connecting rod in front. Advantages are that the bone is thick and strong, and it gives you a better stability, and it can be quick if you are experienced with that. But the disadvantage, you have to be aware that it can cause hip joint penetration if you're not too careful or not using the C-arm. Neurovascular structures are quite near, especially near the greater sciatic notch. Lateral cutaneous nerve is at risk. And if you use pedicle screws instead, and you use a bar which can be shoved off subcutaneously, so that is what an internal fixator is, or an infix. So here, an example where a posterior injury has been managed by iliosacral screws and the anterior injury was managed by an infix. So you target the beginning area where you small complaint of lateral femoral cutaneous nerve irritation or heterotopic ossification and impingement to the important neurovascular structures. It is important to realize that conventional anterior external fixator, although does not provide posterior stability, it can, in fact, if not properly applied, can potentially increase the displacement in vertically unstable pelvis. And frame design should be such that it allows access for laparotomy and future room for abdominal distension. Coming to the C-clamp, it gives direct posterior compression and stabilization in a posterior pelvic ring injury in a hemodynamically unstable patient, where the site of entry is exactly where you almost choose for do your iliosacral screws, a plumb line from the ASIS and a line along the tip of the greater trochanter, where the two lines meet is probably your site of entry. So you can do it without a C-arm also, but you have to be careful while doing the same. While reducing, you have to apply lateral compression, traction, and internal rotation as you would do for an anterior frame also to reduce the fracture and provide hemodynamic stability. Beware that if there are any fractures in the iliac vein or at the entry site comminution, so you will not be able to use a C-clamp. So again, you will have to either choose a pelvic binder for that or use an anterior frame with proper technique. It is a technically demanding procedure. You need practice, and poor placement may actually lead to perforation of the iliac vein and can compromise future sacroiliac joint screw insertions. So coming to the disadvantages, what in the large series which was done from 1999, 110 pelvic fractures, the most common complication was actually a malunion, and the more the fracture is unstable, the more the chances are the fracture will end up with a malunion, and non-union also is seen in some cases, and patient does not accept that well easily. So the take-home message is that all methods of external fixation, like even a simple pelvic binder, this has largely replaced a C-clamp and an external fixation for acute control of hemorrhage. If you just want to remove the pelvic binder for a replacement with an X-fix, that is not actually suggested. There is no evidence to support the same. You will need a pelvic fixator if there is pelvic instability, and especially in the face of a laparotomy, pelvic packing, or embolization, or there are open fractures to deal with. You need diverting colostomy. There is suprapelvic catheterization, which is also needed. So you will need a supplemental external fixation in all those resuscitative indications. Timing is actually of more critical importance than the method or type. And definitely, you can use the low route of fixation anterior frame as an example to process sacroiliac fixation. Thank you. I cannot hear you.
Thank you, Puneet. Such an informative talk. Any questions from the panel? So which route you prefer in, because this patient is unstable patient, Puneet?
Yeah.
So which route? Because supraacetabular route, invariably, obviously, you cannot do it without C-arm guidance. So in emergency situations when you have to hurry up, I think iliac crest route is still the preferred route. I think everyone would agree with me, all the faculty.
Absolutely. Yeah, because timing is critical.
Vijay sir,
Dr. Vijay, Dr.
Kong is having question.
Dr. Kong.
Yeah, Dr. Kong.
He is having questions, sir.
Okay, I press the space bar. Can you hear me?
Yeah.
Yes, Dr. Kong.
Yeah. I think I tend to disagree with Vijay. I think the anterior low root is faster because we use C-arm. If you don't use C-arm, you are doing blind. I think the external fixator on the iliac crest can be sometimes very difficult to find, especially when there's a fold of large abdominal fatty tissue, especially with the pelvis in the unstable position, and if you don't have the C-arm, you can't get the outlet oblique view. Try to get the outlet oblique view, and then you can get your direction quite right when you don't have to worry whether it's 45 degrees or 60 degrees. So since we get the C-arm, I might as well put a single anterior low root pin on each side rather than 3 high root pins on each side. So it does save time, but of course requires some experience and the use of proper equipment.
Right. So you want to say even iliac crest pins, they are always used. They should be used under C-arm guidance.
Well,
Even the
usually you are not the one doing it. It's a junior doctor doing it.
Yeah.
And usually you will find in most post-op CTs, many of the pins could be more than
lateral,
many of the pins are actually out of the inner table. So, or the other way in the outer table. So they are not actually, when you compress them in the tips are outside the outer table, they're not actually affording any compression at all. So if they're at the risk of being more fixable, you should go a little bit more than 45 degrees and 60 degrees. The pins end up in the iliac fossa on the inside. At least when you close the book, it is buttressing the inside of the inner table and therefore more effective as closing the book better.
Thank you, Dr. Kong. Dr. Inder, you want to say something? You want to add something? Inder is there.
I think Abhay has a question.
Okay, I think
Abhay has a question.
okay, any other questions?
Sorry.
Okay, Dr. Vineet.
Yeah, so can I just make a comment?
This was.
Yeah.
Yeah, so the other thing is that if you have enough time to do an obturator outlet oblique view, then it also is a wonderful position to put in a very, very quick, fast iliac crest pin, because you see the entire profile of where your pin is going
Inner
to
table, outer table. Yeah.
Absolutely. So you can use one supraacetabular and one iliac crest pin, and that actually is one of the best constructs for an pelvic external fixator.
Yeah.
Same thing.
So let us go ahead with the Dr. Vineet. Yes, sorry.
Yeah, same thing, Vijay. I just also wanted to say the same thing as Dr. Abhay, because adding one iliac pin and another supraacetabular pin, both can work well if you have got time to use a C-arm. Of course, we are not doing in emergency. It is being already done in the OT.
Yeah, but what I was trying to say, if C-arm is a problem, then out of these two pins, still you can put iliac crest pin by putting the conventional K wires and then directing it towards the iliac crest.
Yeah,
so, okay,
yeah,
I think let us go ahead.
definitely.
So let us take the case forward. So this is the same patient, and the patient is still hypotensive and tachycardic. So fixator chap is there, Dr. Puneet is there. So what is the next line of defense? So obviously, I think Puneet has also mentioned it is either doing a pelvic packing or angioembolization. It depends upon the facility also. So I would like to call Dr. Amit Gupta to share his experience on the next lines of defense about pelvic packing and bilateral ligation, surgical ligations.
So one has to unmute Dr. Amit Gupta.
Okay. Thank you so much, Dr. Vijay. Am I audible now? I think I must be audible now to everybody.
Yes. Go ahead.
Fine. So basically, I'll pick on from where I had left, and Dr. Puneet has made my job very simple. And I will just give all the students here and all the clinicians, orthopedicians here a view of how trauma surgeons look at pelvic fractures. Obviously, I would continue with the same case as we were dealing with. Already applied a pelvic binder, and we assess the patient once again. So after initial resuscitation of crystalloids, blood and blood products, we try to assess the response to resuscitation. So the response could be, in any given case, as Dr. Puneet said, a rapid responder, who responds to your crystalloid challenge, a transient or a non-responder. Now, the problem is with transient and non-responders, especially with transient responders, because these are the patients who give you sufficient time probably to go to the CT scan and get the imaging done of the secondary survey, but they do not give you much chance after that. Non-responders are obviously another entity which are in extremis, and therefore something needs to be done very, very urgently to stop the hemorrhage. Otherwise, these non-responders would actually go into class 4 hemorrhagic shock, the Redding syndrome, or the trauma coagulopathy, as it is said. Our patient, after resuscitation, had a heart rate of 110 and a blood pressure of 90/70. And clearly you can see that the patient is a non-responder. Now, in any given non-responder, that means he has hemodynamic instability despite fluid resuscitation. He also has an unstable pelvis. So our focus would be probably that his pelvis is bleeding into the retroperitoneum. So we have two subsets of patients here dealt with in the emergency room by the trauma surgeons or general surgeons. Unstable pelvis or unstable patient, unstable pelvis along with fast, which is positive. That means showing blood in the abdominal cavity. Or a patient who does not have fast positive, that means fast negative. So what to do? So the next step is simply stop the bleeding. We've already tried stopping the bleeding by applying a pelvic binder. Probably it is not working, and therefore we need to now do something more. So what is the armamentarium we have in a non-responder who is going into extremis? It is obviously, as Dr. Puneet said, pelvic packing. Pelvic packing, and I would go into a little bit of more detail about what you understand by pelvic packing or perivesical packing. It can be done with or without bilateral internal iliac ligation. Now, there's a lot of controversy about bilateral internal iliac ligations, but a patient in extremis who is alive is probably better than a patient who's dead. So we do at the trauma center at AIIMS bilateral internal iliac ligation very liberally. Liberally, I mean to say, obviously, those patients who remain unstable despite blood transfusion, repeated blood transfusions, they are going into extremis, and we don't have any other option but to ligate the internal iliac arteries. We also have angioembolization facility, but obviously Dr. Shiva would be taking up the angioembolization facility, the indications for angioembolization, and they are generally done in responders or transient responder patients. Till then, we continue to transfuse and resuscitate and shift the patient to the OR. Our patient was posted for laparotomy because he was fast positive within 1 hour of arrival. Important operative findings were that he had a large retroperitoneal hematoma. So the bilateral internal iliac artery ligation was done along with pre-peritoneal perivesical packing. Now, just a word about pelvic packing. How do we do it? So generally we have two approaches as trauma surgeons. One, when the fast is positive. Obviously, when the fast is positive, there might be other organs bleeding in the abdomen, something like liver or the spleen, for which you need to do a splenectomy, or maybe a mesentery which is torn, you need to do that, or maybe some of the organs of the pelvis itself, something like bladder, they might also. So soft tissues within the pelvis are so many that any one of them can get injured and can bleed, giving rise to a fast positive. So we need to open the abdomen. But at the same time, what we actually do as trauma surgeons is that we try to make, once the laparotomy is done, we try to, from the inferior part of the incision, which we have given, we try to peel off the peritoneum between the bladder. So we open the space of Retzius, and you won't believe it is so easy to do it because already the blood is there, already the clot is there, and therefore it does not take a real effort to actually peel off the peritoneum, enter the true pelvis, and evacuate the hematoma, see for the active sites of bleeding. If you can control it, very good. If you cannot control it, we actually, the first reaction is to pack them, pack both sides of the bladder so that the bleeding stops. But if the bleeding is not stopped, or your packs are getting soaked again and again, the extreme step is to ligate the bilateral internal iliac arteries. The other option would be when the fast is negative. There you have time, and probably you can, what we say, have a extra peritoneal approach completely. You might do it with a midline lower abdominal incision, enter into the space of Ritzius and just anterior to the bladder, and make space on both sides of the bladder, and then introduce the packs there. Generally, the operating time in any damage control surgery should be total operative time should be under 45 minutes, and this packing procedure should take less than about 20 to 25 minutes. Can we control the arterial bleeding? As I said, we might not be able to control the major arterial bleeding, but we could minimize the pressure heads by doing a bilateral internal iliac ligation. External fixator already dealt with in detail by Dr. Puneet, so I'll not go into it. But obviously, because we are packing, we need to reduce. We don't want to introduce packs after packs. We need certain limit of the pelvic volume, and therefore it is an adjunct which is generally used along with pelvic packing. Well, just a word about, does it affect the future definitive management in terms of infection rates and complications? Generally, our series of more than 500 patients, and Dr. Vijay would pitch in for me, not many patients have landed up, if they have lived to survive the initial hemorrhagic insult. Not many patients would have had long-term complications. Well, do we need embolization after packing? Yes, generally our practice is that just before the pack removal, we would, if the patient is stable enough, we would ask our interventional radiologist to do a quick run of the dye and see if there is a definite sort of pseudoaneurysm or some bleeding left. They would embolize the internal iliacs with a gel foam, and then probably we might go ahead and remove the packs after that. Just a word about bilateral internal iliac ligation. Obviously, hemodynamic instability with fast positive, which we encounter expanding retroperitoneal hematoma, it does depressurize the pelvic vasculature and helps our packing. So it is not that we are doing bilateral internal iliac ligation just like that. We complement it with both external fixators as well as pelvic packing. It has gone into disrepute because of some complications, but believe me, out of our 450 to 500 cases which we have done, I have personally not seen any of these listed complications like rectal stenosis or colonic problems or gluteal muscle necrosis, sacral skin necrosis. We've never seen. As far as importance goes, none of the patient coming in the follow-up has reported. So although we need to do obviously a follow-up study of importance, but till now, none of them have voluntarily reported that they are having importance. Just a couple of videos, very quick videos, just to tell. So this is the pelvis, that's the caudal end. This is the cranial end on the right side. This is on the left side. You can see, I'll just run it on the right side first.
This is a case of pelvic fracture. He was a non-responder. He was a pedestrian hit by a four-wheeler, and he presented to us in a state of shock. We resuscitated him in ED with 1 liter of blood and 2 PRBC, but his BP didn't shoot up, so we had to take him for surgery. He was fast positive in abdomen, gross urine. We explored the retroperitoneum, and there was a diffuse bleeding. Fracture of the pelvis bone was there, internal iliac artery of the right side. As you can see here of the right side, this is the internal iliac, and if I can show you, this is the external iliac. This is the external iliac, internal iliac, and common iliac. Now we are going to ligate the internal iliac of the right side. We can do both ligation and clipping. I personally prefer clipping, so I'm clipping the internal iliac with 300.
Similarly, on the left
We have ligated the right side internal iliac artery. Now we have proceeded to the left side, and we have dissected out the common iliac, the external iliac, and the internal iliac. I'm going to clip the internal iliac with 300 Liga clip. I've ligated the right side internal iliac artery. This is a case of pelvic fracture.
So I think I would leave on that and would say that probably the management algorithm of a patient who's both having an unstable pelvic fracture along with hemodynamic instability, fast is crucial for surgeons. If it is positive, you need to do exploratory laparotomy along with obviously plus minus bilateral internal iliac ligation. You need to do a fixation, external fixation and pelvic packing. Obviously, if the fast is negative, the patient becomes stable or is a transient responder, probably you might try angioembolization along with fixation and packing. So the take home is life is more important than probably anything else. Manage the patient as per the ATLS protocols. Know the indications of pelvic packing, plus minus bilateral internal iliac ligation, which is extremis, patients in extremis, and the definitive management of pelvic fractures would come only after the patient has been stabilized. Thank you so much. I think I'll leave on to that to Dr. Vijay.
Thank you, Amit. Such a wonderful talk. I think any questions from the panel?
Can I ask?
Yeah, Dr. Vijay.
Yes, Dr. Sharan.
Dr. Once if the patient is non-responder after a pelvic binder, would you like to try first external fixation and then go for, if it doesn't respond still, then you go for packing and other things, or straight away from pelvic binder to the packing and those procedures?
So I would say, sir, if it is fast positive, I'm more worried about the uncontrolled hemorrhages which is happening in the general peritoneal cavity. So I would call up my orthopedic colleagues along with me. So it's more or less a simultaneous procedure. I would open the abdomen, pack. Maybe if the liver is there, pack the liver. If the spleen is there, take out the spleen. These are the two organs which can cause really massive hemorrhage within time. So I would not probably in a fast positive, I would not look ahead and do a external fixation first. But yes, if the fast is negative, if it is a contained hematoma, again, the fact remains that it is always better if it is done as a teamwork. But if not, then obviously external fixator is much robust than a pelvic binder. You might go ahead. So these are dynamic patients. I would not say one thing would fit or one thing would fit every patient. I think we need to tackle this patient by patient.
Dr.
I think,
Vijay,
Amit, I think the questions orthopedic surgeons want to ask is fast negative unstable pelvic fracture. Fast positive, we know patient will go to OT, laparotomy will be done, and then further procedures.
So, so if it is fast negative and the patient
fast negative unstable pelvis, bleeding unstable pelvis. So
absolutely. So if it is fast negative, the patient still is having some amount of bleeding, and you are taking him for pelvic. So obviously you cannot manage this patient in the ED. You will have to shift this patient to the OR and tackle there. So if the orthopedic team is there and they are the ones who are packing the pelvis, I think you can apply an external fixator first to reduce the volume. And then after that pack, in that case, the packing becomes more effective because the volume is already reduced and the packs would probably work more. So that's the message from my side.
Dr. Vijay, Dr.
Abhay has a question. Okay.
Sir, Dr. Inder Gill also has a question. Dr. Vijay.
Yeah.
Dr. Amit.
Yeah, Dr. Inder, yes.
Well, that's an excellent talk, Dr. Gupta. What I would say is one or two comments. One is about the hemodynamic instability, although I joined late, but you presented the patient with a BP of 90 and a heart rate of 110. And at least in our center, we would be aiming for that, really. We wouldn't be aiming for a normal blood pressure. So that, that's what we are looking at more and more. So whether it's hemodynamically unstable or not, that's questionable. And in most of our cases, those patients will go to a CT before doing anything. Secondly, regarding internal iliac ligation, what I wanted to ask is whether if you're not doing a laparotomy and just doing a pelvic packing, how easy is it to do? Because I think the visualization would be difficult in that scenario.
Again, you're very right that it might be difficult in the hands of people who've not done it before. It needs certain amount of expertise. I would not say that it doesn't need expertise. And there have been reported complications like ligating the external iliacs instead of the internal iliacs. So yes, it should be done by the most experienced person in the team, whosoever is there. and it is a procedure which is slightly difficult. But nonetheless, if you have experienced people, it is not that difficult also. We've done a considerable number of internal iliac ligations, even in patients in which we are not opening the peritoneum. In which we are
I think
not
we'll have
opening
last
the
question from Abhay. I think Abhay is.
Vijay, one
wants to
question
ask
from
something here.
Yeah. So my
Okay,
question
Vinit, yeah.
is that are you routinely doing an angio check before removing the packs? And second is that what is the incidence of pseudoaneurysms which you've observed?
I think the pseudoaneurysm part, Shiva would deal better. I think I'll leave it on to him. But we are not routinely doing before pack removal in all cases. Again, as I said, no, panacea or single drug for all patients. It is in those patients in which we have felt during the packing that the bleeding was really bad, and then probably it was more arterial, but it has got controlled with the packing. Then probably before removal of the packs, we would ask our interventional radiologist to go once and see if it is a branch artery, or even they have done sort of main internal iliac embolization.
Shiva is going to talk about that in detail. I think one more just point I want to make before switching to the next talk is impotence. I think Vivek is looking after, we are looking after. I think you said not even a single case. I think we'll have to relook at that because the impotence rate is quite high. Maybe we don't ask them, but they don't tell us. But Vivek is doing work on that. I think it's quite high number.
Yeah, so I didn't venture into Vivek's sort of talk, but obviously I said that we'll have to look into it. Our data, we'll have to call back these patients on follow-up, and then probably publish it whatever the rate is. And take that as a pinch of salt, because these were the patients who were actually dying on the table. So as I said, this is a procedure which is not done routinely. It is done in patients who are actually, you feel that they'll die on table. This is a very, very sort of salvage.
You feel that life is more important than anything else. Yeah,
absolutely.
Vijay, one second. Vijay.
Okay, Dr. Vinit. Last question from me.
Yeah. Last thing. Dr. Amit, this is a nice presentation, but we just want to know, in addition to what Dr. Vijay has said, as an orthopedician and operating in a hospital where we don't have a team who can intervene as an interventionist for embolization. I have got patient which is unstable, fast negative, pelvic unstable, bleeding. I have applied fixator. It is not working well. Then what is the next step? If I have to transfer the patient to a higher center, is it the right time, or should I wait for some other procedure?
So it depends upon what your setup is. As you said that your setup is not geared up for any intervention to reduce the bleeding. The key is stop the hemorrhage by the means you are comfortable and you can. So stop the bleeding here means external fixator you have already applied, it has not worked. So the next steps obviously are to do a pelvic packing. Now, if you think that a pelvic packing could be done, say within the acceptable time of 25 to 30 minutes, your ORs are ready or you have blood, then probably it is the right time to go ahead and pack and then send the patient. But if you feel that your hospital is not geared up with a blood bank or probably with the OR, which is 24/7 ready, then I think after application of external fixator, that's the right time probably, along with the blood and blood products and somebody, you should transfer this patient to the nearest appropriate facility.
Okay, Amit, I think we'll have to switch to the next talk. That is going to be, thank you, Dr. Amit, thanks a lot. I think next speaker is Dr. Shivanand Gamanagatti, he's the intervention radiologist. So Shiva, you are ready with the presentation? Okay.
Okay, so can you hear me?
Yes.
Okay. So our role comes in a very particular setup. I will show you one case scenario and later show some examples. So this is a 33-year-old female who encountered a road traffic injury and presentation to our ED department. Her BP was 90/60 and she was tachycardic, and based upon the ATLS criteria, her fluid resuscitation was started. This was the pelvic X-ray that shows APC3 type of pelvic fracture. And after the fluid resuscitation, she responded to fluid and the BP came to around 100/70 after 2 hours. But the BP was variable and the tachycardia was persistent. So she was labeled as a transient responder. So in this setup, these are the 3 options we have, whether the patient should go for a CT room to look for the source of bleed and other associated injury, or patient should go for a OT for packing. But in this case, since we have a 24/7 availability of a IR person, and I was doing a case for another patient, this patient was immediately taken for angioembolization. In this case, what we found was the left internal iliac artery was completely disrupted with active extravasation of the contrast. And we put a coil at the internal iliac artery at the site of bleed, and hemostasis was achieved immediately. And her BP shot up. And this is the ideal situation for angioembolization, the patient transient responder with immediate availability of the facility and IR person. The other situation where we play an important role is after the packing, if the patient is, the surgeon feels that there is a continuous ooze, there is ongoing bleed, then that is one situation. Second situation. The third situation is the stable patient where we have done a CT and CT shows the signs of active bleed. So these are the 3 situations where we play important role. So regarding the patient goes for CT, DSA or OT, it all depends upon the hemodynamic status. This is already discussed. Stable patient will go for CT to look for the source of bleed and associated injury. Unstable patient go for OT, and transient responder, if you have a facilities, availability of the IR person, angioembolization. In our center, this is already discussed. I will not go into detail. So our role comes is the transient responder, but fast is negative, where angioembolization plays a role. The main limitation is the time, availability of the DSA facility, IR person 24/7. These are the main limitations. If you look at the angioembolization, takes about 1.5 hours to 2 hours to mobilize and shift the patient to the DSA room, whereas pelvic packing takes about less than 30 minutes. So coming to what are the vascular structures which get injured in these arterial sources of bleed? Usually this is a combination of multiple arteries which get injured. The most commonly one are the internal pudendal, and the other one is the superior gluteal. So coming to here, these are the CT images which are done in a stable patient, showing the signs of active bleed. If you see here, there is an active extravasation contrast in the region of the internal pudendal artery. This is another case. There is showing an active extravasation in the relation to the iliolumbar artery. And third case, this is the active extravasation in relation to the inferior gluteal. So these are the various angiographic picture what we get encountered in our center. This is a disruption of the internal iliac artery. This is a bleed from the internal pudendal. This is the typical picture what we get. Injury of the multiple branches. If you see a active extravasation from the multiple branches. So main goal of embolization is to achieve the hemostasis rapidly without wasting a time. We don't go selectively embolize each and every branches. We plug the gel, both anterior division as well as the posterior division with a gel foam and put a coil. So I will show some example. This is a typical example what we encounter in a complex unstable fractures. This is areas of active extravasation from both the anterior and posterior divisions on either side. We plug the distal bed with a gel foam and put a coil in the proximal internal iliac arteries. This is a case of a pseudoaneurysm arising from the obturator artery. So when we see only a single vessel which is bleeding, then we go selectively and embolize it. This artery was bleeding, pseudoaneurysm was coiled. The other example is this is a very rarely affected branch, that is iliolumbar branch. If you see here, there's an active extension of the contrast. So this was picked up on CT and subsequently angioembolization was done in this case. So CT is done in stable patient that will help to identify the source of bleed in the form of active extravasation or pseudoaneurysm. So this was a pseudoaneurysm from the inferior gluteal which was embolized. So efficacy is the success rate is about 90% and the failure rate is about 10% due to the patient is in shock. You can encounter technical difficulties to cannulate these arteries. And the complication rate usually 5 to 10%, usually they are minor. Sometimes you may encounter gluteal necrosis, very rarely. And the chance of recurrent hemorrhage is about 5 to 8%. So this is my talk. If you have any question, I'm happy to answer.
Thank you, Dr. Shiva. Any questions from the panel regarding this embolization talk? Am I audible, Shiva?
Yeah, you are audible.
So when do you use gel form? When do you use coil? And it is something permanent or it is temporary and it gets recanalized after some time?
Gel form is a temporary. It takes about 1 to 2 weeks to recanalize. And ideal situation is that if there are multiple branches are injured, then we put a gel foam and proximally put a coil so that it should not bleed again. If there is no active extravasation, there is a suspicion of only venous bleed, then we put a gel foam, we don't put any coil. And the coil is used only whenever there is a pseudoaneurysm or active extravasation when we are going selectively.
Right. So I think any questions from the panelists or any comments, Dr. Kong, Dr. Inder?
Yeah,
Yes, Inder,
so
please.
just one thing. Obviously, you told us about the embolization, and it takes about 2 hours to do. So I think in an emergent situation, would you say that it's better to do pelvic packing first and then see if he's still unstable and then consider the embolization, or whether it's the other way around, which is better? In your experience, what do you say?
No, the 1 to 2 hours is the situation where you have to mobilize. But if the IR person is available on site, it is just shift the patient. If you are finding it is a transient responder. Once while you are resuscitating, we mobilize it. In our center, we mobilize even IR person. So we needed that support. So once we label this patient as a transient responder, then only we take, not as an unstable patient.
No unstable patient goes for embolization, I think.
Yeah. Only transient.
I think we have seen fixators, we have seen embolization, pelvic packing, and all sort of emergency management. So now I invite Dr. Inder, Mr. Inder Gill, to present what exactly happens in NHS and England hospitals regarding ED management of unstable pelvic fractures. Inder, you're ready with the talk?
Yeah, I'm just going to share.
Yeah.
So can you see the screen?
Yeah.
Just trying to, yeah, okay. So I'm just going to talk about what happens in UK. There might be a bit of overlap from what you've already heard. The main thing in UK practice is that, first thing is that most of it is protocol based. So we have protocols for management of pelvic fractures, and they have designated trauma centers where you would get the patient in. So it's very unusual that the patient will go to a hospital where the facilities are not there. So we've got guidelines, as with most things in the UK. So we've got guidelines from British Orthopaedic Association regarding management of pelvic fractures. And regarding acute ones, the main things are obviously pelvic binder, which is essential. And in most of our cases, it is pre-hospital that they all come in with a binder already applied. And as I said before, they would be transported to a major trauma center where there would be most of the facilities available. We also use Tranexamic Acid within 1 hour if possible. And again, it's given at the site by the pre-hospital team. And then if they need additional things, then we can give it again. Generally, the initial resuscitation is started depending on how the patient is. Even at the scene, most of the paramedics would have blood, O-negative blood, and FFP with them. And as ATLS, things have changed and moved on, and the main thing is to start blood early as soon as possible. Most of our hospitals have what we call as massive transfusion protocols, where you have the transfusion packs and they have a supply of O-negative blood, FFP, as well as platelets, which can be initiated very quickly. So that's an advantage we have. CT scan is used liberally in all polytrauma patients. We've got a target of all major trauma. Within 30 minutes of arrival to the hospital, they should have a span CT, which means from head to the pelvis, with a scanogram of the rest of the extremity as well. Most of our CT scanners are co-located to the ER, so it takes less than 5 minutes for them to go in and come out. And the traditional zone of death associated with CT is not really applicable at this point. So we use CT a lot. And as a corollary, we use fast scans much less. I know all your protocols have been based on fast scans, but we hardly ever do a fast scan, very, very rarely, unless the patient is completely exsanguinating in front of you and there's nothing else. And in that scenario, most often they will just directly go to theater. So the definitive management of the pelvis should be done within 72 hours. That is not the acute management, but the definitive management. So as we know, there are 4 possible scenarios. And what we are dealing with here is an unstable patient hemodynamically as well as with an unstable fracture. And as you've heard before in the previous talk, the main way of maintaining or resuscitating them would be to maintain the fracture reduction, which maybe use a binder or an external fixator to do that, aggressively resuscitate. That is the most important and the key that we have found. We found pelvic packing and embolization is used less and less in our scenario because we resuscitate very aggressively and resuscitate early. And I think that is the key of avoiding most of the other things which are, I know Dr. Gupta said 500 cases. I think we probably do 5 cases of pelvic packing in a year, if that's so, even less probably. So acute management, as I said before, what we will do is as soon as the patient arrived, make sure that the pelvic binder is on, make sure it is at the right level, because quite often it can slip when it's been applied. It can be higher up or lower up and not doing its job. Aggressive resuscitation with the tranexamic acid and massive transfusion protocols. CT scan with contrast, again within 30 minutes of arrival. And if there is still persistent instability in spite of doing all those top 3 things, then you have to think about, well, whether we need to do an embolization or whether you need to do packing in theater. And that again depends on individual protocols in the hospital or availability of people, as we said, whether they are on site or not on site, and what's the experience of the team. So as I've said before, binder has essentially superseded the X-fix in most of our cases. We hardly ever apply an emergency X-fix using iliac crest. The only time we use an X-fix is, again, if it's an open fracture and there's a lot of contamination and the binder is actually causing a hindrance in assessing the wounds, etc., then yes. If there is a significant soft tissue compromise, you don't want to apply a binder which will cause more soft tissue problems, then okay. And rarely if the patient is going for an open packing and you want something to pack against, then we can use an X-fix. However, a lot of people nowadays even pack against a binder, and that's quite effective as well. So what I'm getting at is that we are using X-fix in an emergency role very, very less frequently. And we just manage with the binder and then do a definitive fixation. We can use an X-fix as a definitive fixation, as we've heard in the previous talk, in some sort of fractures where we commonly would use an infix. But as an emergency tool, it is much less frequently used. So resuscitation, as we said, what kind of resuscitation we need? Obviously, what we call as permissive resuscitation. So maintain a blood pressure which is lower than normal, because you don't want to get a blood pressure higher than 90 because it can dislodge your early clot. And that's the key to form an early clot which will prevent the bleeding. As I said before, early administration of blood products and components, minimal crystalloids because they don't help. And as we said, to avoid the lethal triad of coagulopathy, hypertension, and acidosis, give red blood cells, fresh frozen plasma, and platelets. And as you all know, it's a 1:1:1 ratio nowadays. It used to be 3:1 and 6:1, but now they say the products are as essential as the blood because that's what achieves your hemostasis. Tranexamic acid, routinely used during the initial phase as well as definitive surgery. Reboa is something which you may have heard about, which is endovascular balloon occlusion of the aorta. And this is for a patient in extremis, where you are just thinking of opening the chest and doing an external massage or clamping the aorta through opening the resuscitative thoracotomy is what we call. So this is something which is alternative for that. And in some places they have experience with it. Most of the experience is from defense guys where it has saved life, but it's not routinely used in our practice, I must say. But it's something to keep in mind. Maybe in the future that might be an alternative and to train people according to that. So source of bleeding, as you all know, there's low pressure system, which is the broken bones and the torn vessels, essentially the vein, and then you've got the high pressure system, which is the arteries. 90% of cases, the bleeding is from the low pressure system, where pelvic packing is the effective treatment, and in 10%, it's the high pressure system. So that might help to judge in what you want to do. But as a corollary, when the patient is hemodynamically unstable, the arterial lesions are more frequent. So although they are 10% in the total scenario, they can be more frequent when there is hemodynamically instability. So keep it back of your mind and just don't discount embolization if that's available in your center. Now, what's the problem with pelvic packing? Well, in our practice, one, it is invasive, you all know that. Secondly, it may not be effective when there's a large bore arteries. So maybe addition of internal iliac ligation is something which can be considered. Means I don't have personal experience about that. And if we are doing packing, we wouldn't be ligating the internal iliac, but it's something to consider, I think. And obviously it needs another operation to take the packs out. So which is again a disadvantage, but obviously the advantage is it can be done much quicker. Patient is already in theater where you are putting the X-fix on. It's another quick 20 minutes to do it. And it's quite easy to do. What about embolization? I think in our practice, the disadvantage is that it is time consuming. It's difficult. You have to get the person on site. You have to do the angiography. You have to, and because it's in a separate theater, you can't do simultaneous other procedures like putting an X-fix or putting a packing done. And as I said, it needs availability of adequate staff, which is trained, and you have to transport the patient to an angiography suite, which is a problem with embolization. In the future, we are coming up with what is known as hybrid suites, where you can do angiography and theater at the same place, so you don't have to shift the patient again and again. But I don't think, well, we don't have that available yet, but that's coming in our center. So to conclude, most important thing is know the resources that you have, as there was a previous question about when to transfer. So know the resources, know what you can do and the limitations, and when to transfer early, and maintain or make protocols for your hospital. Follow ATLS principles, as you know. Classify patient's condition. Again, we know about that: transient responder, non-responder, or responder. Initial steps is close the tap, as you know, stabilize the pelvis as best as you can with either a binder, rarely with an X-fix. Think about packing or embolization depending on your resources, experience, and the condition. Important thing is to remember is that both of them are synergistic and not antagonistic. So even if you've done one, there might still be a role for the other, and vice versa. I think that's all for me. Thank you.
Thank you, Inder.
Dr. Vijay,
any questions from the panel? Yeah.
Dr. Vijay, very surprising. We have 1400 logged on, but still no question from the audience. So you can continue.
Actually, audience is more interested in the next phase. Actually, they are more interested in the definitive fixation.
Oh yeah.
So maybe you will find a lot of questions in the next one or.
Okay. Okay.
So because the pelvic fracture has two phases, initial phase, obviously, actually in our institute, all the unstable patients, they are taken care of by trauma surgeons. We only get involved when patient is stabilized. So I think the same is there in the NHS also.
No,
it's a combined care. There's some.
We would be involved much quicker. We don't have dedicated trauma surgeons. We do have general surgeons who would do, some of them would do the packing, but most of them won't. And unless the patient needs a laparotomy, then yes, we'll do a combined procedure with them.
Dr. Vijay, can I ask a question?
Yes, sir.
Dr. Inder, excellent presentation. I just want to have one clarification that your paramedics have all the blood products with them, the PRC, the platelets, FFP. So they're able to decide before reaching the hospital what to be given without any blood investigations, or this is some protocol, they follow it and then you take it over later.
So they don't cross match. They have O negative blood on site with them. And they get FFP, which is again O negative. So those are the two things. They don't have platelets and stuff, but if the patient is very, very unstable, they can't get the BP up, they'll start the blood en route to the hospital. So we can do things.
So when to give blood, when to give FFP, they're able to decide that?
Yeah, they can decide it, yes. They are able to prescribe blood and decide how to give and when to give.
So I think patient is stabilized, and now we are looking at classifying the patient and doing definitive fixations. Now you will get a lot of questions, Manish. Yeah.
Dr. Vijay, one thing.
Okay, Dr. Vineet, yes.
Dr. Vijay, yeah, the Dr. Inder has suggested now that they want to maintain a low blood pressure. But here in India, in the scenario which you are discussing, the patient's BP is 90/70 and HR is 110. So do you think both the things are contrary to each other? He is trying to lower down the pressure so that there should not be any problem. But we are considering as a problem and we wanted to upgrade the blood pressure. So what is the message for the resident doctors?
No, I think, Inder, you want to say something?
No, I just wanted to say, yeah, means they can be contraindicatory sometimes with tachycardia and hypotension. Yeah. But obviously the tachycardia, there can be 100 other reasons like pain, anxiety, being in a hospital per se. So it depends on, how comfortable, and if you can do an aggressive monitoring of the patient and you have everything that available, then I think maintaining it at 90 is what we would do, because increasing it too quickly, too much will dislodge the clot, and that causes more problems.
Okay, I think now let us switch over to the next part, which is definitive fixation part. So the first talk is by Dr. Abhay Lenz. Abhay, you are ready with the talk? Dr. Abhay? Okay, yes.
Can you see now?
Yes, Abhay.
All right, so once we have a stable patient, the important things that we need to understand in the coming 10 minutes is why classify. So the value of a classification system is it explains to us the mechanism of injury, and it quantifies the level and severity of damage, wherein we need to do special scans, special views, special scans, like CTs and CT angios for these patients. So as I said, it defines the mechanism of injury. It helps us to quantify the severity of damage. It helps us to predict the prognosis of injury, and not all classification systems do that, but the Young and Burgess one does it. And it assists the surgeon in selecting the appropriate treatment for a given situation. So just to run through a case before we discuss the nuances of what we come across, this is an injury which in experienced hands is very clearly a vertical shear of the hemipelvis on the left side. But we're still not very sure that how much of the pelvis anteriorly is superior and how much it's gone posterior. So we need special views, which are the inlet-outlet views, and which will help us to quantify what exactly is happening in the individual pelvis. And once we have that, we need to do some additional workup, wherein we do some additional scans, which will help us to know what is happening to the pelvis behind. So if you see, the pelvis is opened up posteriorly, so definitely there is both the anterior pelvic ring and the posterior pelvic ring instability, and the pelvis is gone superiorly and posteriorly. So this is a combined injury which required surgical treatment, both anterior and posterior, which was treated at a single stage, anterior plus posterior surgical incision. Patient was very well after surgery, and he did extremely well in follow-up. So rather than going into different classification systems, I will just talk about the one classification system, which is kind of become one of the gold standards, as it explains to us what exactly we are dealing with. So the Young and Burgess classification was instituted in '96, and it essentially classifies pelvic injury into 4 types: the APC, or the anteroposterior compression type, the LC or the lateral compression type of injury, the vertical shears, and the combined mechanical injuries. So if you look at the anteroposterior compression injury, essentially there can be the force transmission through 2 routes. One where the force is transmitted from behind, posterior to anterior, which opens up the pelvis anteriorly. And the other where the line of force comes and acts on both the anterior superior iliac spine, again, which opens up the pelvis from because of a force coming from front to back. And what actually happens is the effect of either a posterior to anterior transmission or an anterior to posterior transmission, it essentially tends to open up the pelvis. Wherein what exactly happens is that the symphysis fails, and then does the anterior sacroiliac ligament, the intraosseous ligaments, and then the sacrotuberous sacrospinous somewhere around that. And then once the posterior SI ligament fails, this pelvis tends to become unstable. So if you see here, this is a pelvis which has got its anterior injury in the terms of sectioning of the anterior ligament. And then the next level of failure is the anterior SI ligament, the intraosseous SI ligament, the sacrotuberous sacrospinous, and then the posterior SI joint. So once the posterior sacroiliac ligament goes, the pelvis becomes both vertically and horizontally unstable. So this is a pelvis, and especially the anterior posterior compression type of an injury. What is important to understand is that this is an injury which essentially is involved with a lot of bleeding into the pelvis. So it increases the intrapelvic volume, and you have patients who have, as you see the patient on the left, you can have patients who've had severe bleeding, and this patient incidentally had an internal pudendal artery injury which needed to be ligated through an angioembolization. Coming to the lateral compression type, essentially there can be 3 types: the LC1, the LC2, and the LC3. So predominantly when you look at the LC1s, the force essentially comes from the level of the iliac crest, which tends to buckle or compress the posterior ring, and it tends to fracture the anterior ring as well. If you look at the force which is transmitted at the level of the anterior superior iliac spine, then you tend to land up into situations which can present either with a locked pelvis, and if the force comes laterally from the level of the neck, then these forces not only damage the ipsilateral hemipelvis, but if severe enough, they tend to cause injuries to the contralateral hemipelvis also. So the lateral compression injuries cause both the anterior and the posterior ring damage, and the anterior ring damage essentially is a transverse fracture of the superior pubic ramus in most cases, right? Depending upon the quantum, LC1, 2, and 3, you can have damage to the symphysis, which can be locked. And if you have associated damage not only to the anterior but to the middle part of the ring, where the fracture goes from the level of the SI joint into the crest, into the ilium, and going up to the crest at multiple times. So these are injuries essentially which involve damage to not only anterior part of the ring but the middle and the posterior part of the ring. The posterior ring damage essentially can be of 2 types. One, you can have iliac fractures, which are crescent fractures. So you can have 3 types of crescent fractures, where the fracture exiting through these SI joint can involve 1/3, middle third, or almost a 2/3 of the SI joint complex. So depending upon where the fracture line, the crescent fragment exits or enters into the SI joint, exits the SI joint, you can have 3 different types of iliac fractures, posterior injuries associated with the crescent fracture complex or an LC injury. On the other hand, you can have a sacral fracture associated with an LC injury, wherein the fracture can happen into the ala of the sacrum. Basically, can be a zone 1, zone 2, or a zone 3 injury. So essentially, there is an anterior ring damage, and there is a middle or anterior ring damage, and there is a posterior ring damage. What is extremely important for us to understand is that between philosophically, the APC type of injury essentially is associated with increase in the intrapelvic volume, whereas the LC injuries are basically associated with solid organ damage and not so much because of the expansion of the intrapelvic volume. So the predominant difference between the APC and the LC injury essentially is that the LC injury causes more solid organ damage because there is a compression of the pelvis, except for an LC3 situation where the internal organ can get damaged. In an APC situation, the hemodynamic compromise is what is most importantly seen in these situations. So that's an LC3 injury where on one side there is an LC injury, and on the other side the pelvis opens up. So the pelvis closes on one side and opens up on the other. So this is a very severe type of a mechanism, and this is one of the injuries which definitely needs emergent treatment and probably fixation. So one side internal rotated, the other side externally rotated. This is an LC3 injury. The other types that you see is the locked symphysis, and these are typical situations which surgically can be a little bit of a challenge because the locked pelvis is not easy to reduce, and it needs special equipment and special instrumentation, and the Farabaugh type of clamps are very, very useful in such situations to reduce these injuries. The third is the tilt fracture, and these are special situations where a fragment or a segmental part of the superior pubic ramus can be displaced either anteriorly or anterior-inferiorly. And this is one type of an injury which is commonly associated with dyspareunia or injuries, especially injuries to the bladder as well. So the third level of injury, third types of injury is the vertical shear injury, wherein the pelvis displaces both posteriorly and superiorly. So there is both an anterior and posterior ring damage. These are injuries which are involved with both hemodynamic compromise as well as significant skeletal damage as well. So how do you assess these injuries? So depending upon, do you have an APC or an open book kind of a situation here, and how do you assess this particular X-ray? So the first thing that you need to do is you need to draw your iliopectineal lines and see if there is no associated injury to the acetabulum of the hemipelvis or both the sides. So you do your iliopectineal lines, you do your ilioischial lines, you look at the obturator foramen as a rule, and then you look at what is happening behind posteriorly, and you draw the arcuate lines, as well as you see what is happening to your sacral foramens. And then you have a look at what is happening to your SI joints on both the sides. Once you've done that, the basic question that we are asking ourselves looking at these X-rays is, what is the extent of pelvic instability? So the first thing that we are asking ourselves is there a deformity of the anterior pelvic ring? So once we've done that, and once we've answered that, the basic question that needs to be answered is the anterior ring opening less than 2.5 centimeters, maybe more than 2.5 centimeters, and maybe in excess of about 5 centimeters. So this essentially tells us whether we are looking at an APC1, APC2, or an APC3 injury. So the next question we ask ourselves is that once we've defined what is happening to the anterior pelvic ring, we need to know what is happening to the posterior pelvic ring. And herein we need to do our 2D scans as well as the sagittal reformats, which will tell us exactly what is happening to the posterior part of the pelvic ring, as is visible on one side on this 2D scan, which has a posterior ring injury and an SI joint disruption as well. So the third question we need to ask ourselves is, after doing the assessment of the anterior and the posterior pelvic ring, is that we need to do stress radiographs. So apparently okay looking scans, once the patient is being taken to the OR for stabilization of their pelvic injuries, you do a very gentle pelvic compression, and if you see a more than 10 millimeter collapse on the superior pubic ramus fractures, the innocuous looking fractures, then these are signs that your patient definitely has a fair degree of instability. And the logic behind this is that pelvis in an adult skeleton never breaks from one part. So if you have a break at one point in time, one place in the pelvis, then you have to be very, very sure that on the diametrically opposite part of the pelvis, there is going to be another break. So the next question that we are looking at is that what are the soft clues which tell us about an unstable pelvic injury? So these are essentially a fracture of the transverse process, the L4, the L5, the fractures of the ischial spine and the ischial tuberosity. and sometimes the lateral sacral avulsions as well. So pelvic X-ray in most situations allows us to give a preliminary fracture classification. It provides significant pointers towards diagnosing pelvic instability, but it does not provide enough information for complete understanding of the ring, which is where certain specific views like the inlet and outlet views are required. So these are essentially orthogonal views wherein the plane of the X-ray tube is either perpendicular or parallel to the plane of the sacrum. So if you have an inlet view, you have the patient lying supine and the X-ray beam tilted about 40 degrees or 50 degrees from cephalad to the patient and the X-ray plate behind the patients. And you see what you see on this view essentially is a full profile of the ring, which tells us about the anteroposterior displacements and the rotational displacements of the pelvic ring. What next we need to understand and do is we need to do our outlet views, wherein the X-ray tube shifts about 40 degrees, 30 to 40 degrees caudate, and the pelvis, the patient is lying supine. And what this does is it tells us what is happening to the posterior pelvic ring. So the craniocaudal displacement, the relative height of the hip joints and the limb length discrepancies, and what is happening to the posterior pelvic ring, the sacrum and the sacral foramina are visualized in full profile. So these are the additional informations that we can get from the inlet and outlet views. In certain situations, you need to do your multiplanar 2D and 3D CT scans, which tell us about associated injuries, about bilateral injuries. They give us a profiling of the rotational and displacements of the pelvic ring. And in the end, we need to do CT angios wherever you feel that you have a patient, there are specific indications for it when your patient is not responding, or you have to take in the patient for an intervention. And as Shiva said, that you have your IR person willing and ready in the suite. So the take home for this talk would be that radiology is essential to define the personality of the injury, especially the pelvic fractures. Special views are required to quantify the extent of damage to the anterior and posterior pelvic ring. Multiple classification systems are available, but it is important to follow one, and the Young and Burgess classification is one of the best classifications along with the Tiles classification, which helps us to define the injury. It gives a prognostic guide us this classification, and also helps us to understand and plan some treatment options based on this classification. 2D and 3D CT scans are essential, and they help define the injury, and certain CT angios may be essential in certain category of patients if your hospital has the facility. So thank you all for a patient listening.
Dr. Vijay,
thanks.
Dr. Vijay,
Yeah,
there is a question from my audience. Can I ask now? Or
yes, sir. Please go ahead.
Sir, this is Dr. Ravi Shankar Gaur, and his question is that after pelvic fracture reduction, what is the protocol for DVT prophylaxis?
Hello, Dr. Abhay.
Yeah, so the protocol that we give is that if our patient does not have, we give a routine prophylaxis of low molecular weight heparin 0.6 milligrams once daily. Unless there is an evidence of the patient having a deep vein thrombosis or a PE with a drop in saturation, we don't shift to the therapeutic dose. But yes, our patient does get both mechanical prophylaxis as well as chemoprophylaxis.
For how many days, Abhay, you give?
So the basic thing that we are very keen to follow is that we will start with the mechanical prophylaxis right away, and if there are issues with bleeding, then the chemoprophylaxis can start anywhere between day 2 and day 5. And there is a paper also to say that this combined approach is essentially both safe and it helps in the management of the patient as well. And we continue this prophylaxis for about 10 days to 2 weeks.
Dr. Inder, you want to say what exactly is your protocol for DVT? It's a full debate in itself. So what is your experience like? What exactly you follow in England?
So as Abhay said, we will give initial DVT prophylaxis with low molecular weight heparin, only a prophylactic dose, not a therapeutic dose, unless there is extensive bleeding or there is brain or spine bleeding where we have to liaise with the neurosurgeons. We started within 24 hours, and we would, as a rule, give it for 6 weeks. That's what we do. If the patient is transferred from elsewhere, or if you are concerned that you've not had an operation for 5 to 7 days, then we will do a Doppler ultrasound to look for any proximal DVT. If there is DVT identified and the patient has to have an operation, then he will get an IBC filter before operation.
I think it's a never-ending debate. I think let us not fall into this. Any other questions for Dr. Abhay? It was such a clear talk, I think.
Yeah, my question was whether is there any role for X-rays pre-op?
Yes, of course. So as the patient is wheeled in and they are doing the initial investigation, they do get their X-rays. Definitely, yes. You're talking of plain X-rays or special?
Yeah, plain X-rays, because we don't do plain X-rays pre-op at all. They all get a CT scan, so you don't need any essential views. So
Our place X-rays, then all views, and then CT scan. Everything is there because in operation theater, in operation room, you will only look at the X-rays. There's no CT there, so you have to have idea about all the views there. How to take them, how to interpret them. Yeah.
So my thought would be why a question such as X-rays. Why does that question come from? Is it from the fact that you're extensively using CT scans, so you feel that the need for X-rays is unwarranted?
Yeah, essentially that. We don't, because everybody gets a CT where you can see all the views you want, and you will be screening intra-op anyway. So again, you don't need any specific.
Again, a lot of controversy in this, I think, because at our place, patient comes to ED, and obviously as a part of primary survey, pelvis X-ray is still done there. Cervical spine X-ray, obviously we don't do now, but pelvis X-ray is still done. And then we proceed with CT and all that. But at your place, I think there is no X-ray, it's straight away CT.
For us,
but,
there has to be X-ray. Dr. Vijay, Dr.
Yes,
Kong has a question.
Yes, Dr. Kong, please.
Regarding the X-rays and the CT, we normally have the protocol of the X-rays. If it's a pelvic X-ray, they get all the views, including Jude views and the outdoor views. So it's all done on site. The CT, depending on the patient's fitness to go to the CT scan room, we don't really have it on suit. And secondly is that when they do the X-rays and the emergency setting, is a whole body helical CT. So with contrast, and the trouble is, it doesn't give you a good definition of the pelvis. So after the initial resuscitation, and often we do X-ray, C-plans or binder, then before we do definitive fixation, we do our planning on the dedicated pelvic CT.
Thank you, Dr. Kong. I think next talk is by Dr. Kong only. It is regarding the decision making in the definitive management of pelvic fractures. Dr. Kong.
Dr. Kong, you need to unmute yourself.
Someone, you muted me. Can you hear me now?
Yes.
Yeah, I've done it.
Okay, it's my finger on the space bar. My talk will be a short one on definitive osteosynthesis, but only the principles. I won't go into the details, which will be covered by somebody else along the way. Can you unmute me? Because I'm pressing the space bar and it's moving.
Yeah, we can hear you very well, Dr. Kong. There's no problem.
I know, but I have my space bar. Okay. Wait a minute, I close my.
Please share your slides.
Yeah, you have to start sharing your presentation.
Already started. you see my screen?
No. So on the bottom center of your screen, you will see share screen with a green patch with an arrow on top. Yeah. That's
right. Yeah. Okay. So we go with the pre-op planning. We are assuming now that the patient is quite stable. What you need to do is you have some time to understand the injury mechanism. You would probably have a few days in a few days in ICU. Look at the patient, study the images as Abai has just shown. You have to plan by deciding what you want to do. The main thing is that you have to have a reliable reduction technique.
Oh, your voice is not audible.
Can you unmute me?
So we can hear your voice, but it's not very loud.
Yeah.
Can you hear me now?
You are already muted.
Yes, absolutely.
Okay. So you have to look at the reduction technique, and sometimes we forget to actually put the patient on traction for a vertical shear. We just leave it to the external fixator, and that's not going to reduce the factor alone if it's a vertical shear. Choose safe surgical approaches. Hello, can you hear me?
Yes, you're audible.
Okay. So choose safe surgical approaches. So you need to know your anatomy, study hop and trail if you need to. You must have a sense of timing, and this is very important. You have to have a stable patient, but you must look around to see what else needs to be done. Maybe a fracture, other fractures, or general surgical procedures may need to be done. You need to have a trained team, and I think more important than the surgeon, that is yourself, is the anesthetist and the radiographer. The radiographer is often relegated to the back of the room, but he needs to know what images you want, and so you need to tell him what images you want and trial them out before you take out the knife. Adequate instruments and implants, I don't have to say, but the pelvic implant generally should be available in 3.5, 4.5 sizes. I tend to use 4.5 because they have better hold and fewer screws to do the same job. Then before that, in your consent, don't always tell the patient that they will always have optimal outcome. So make sure they are made aware of neuro and vascular injuries, wound problems, especially if you're dealing with soft tissue injuries as well. And finally, you have to develop an aggressive rehab plan, and that comes straight from ICU, and also to tell your therapist what you plan to do and whether or not your surgical tactic will allow an aggressive rehab plan. While understanding the injury pattern, look closely. Abe already mentioned this locks in physis. Sometimes you skim through and you think that it's a stable fracture, but these often become quite painful when the patient starts to walk, and then it almost becomes impossible to undo them, and you have to excise the symphysis at some later stage for pain relief. So this is an indication for reduction. Posterior lesions, beware of dysmorphism. I managed to pull out this patient who came from me from another country, where someone did a sacroiliac plating, but the proximal plate was at the L5 transitional vertebra, not the sacrum. Associated injuries include acetabular fractures. So when you do your CT, 3Ds are very useful for you to decide surgical approaches. So acetabular fractures, femur, and other lower limb fractures. The soft tissues I will cover in a minute. The tip of this is to study all dedicated multiplanar CT. So looking at this CT on this side, you will see that there is both a right-sided and a left-sided injury. Both of them are completely different and may need a laminectomy for this sacral fracture. And visualize and plan on a pelvic bone. Up to today, I still look at the pelvic bone and then decide on what I'm going to use. And then I have in my mind what implants, and particularly important is the steps that you are going to take and to tell your team about it. The plan is usually work from periphery to center, from a more displaced to the less displaced as a principle. The surgical approach, it can be a single surgical approach. In this case that I just shown with a crescent fracture and a acetabular fracture, you can do it through one. But this patient also happened to have the sacral fracture on the opposite side with a sciatic nerve injury. So you may have a double. So the one could be a minimally invasive approach by sacral iliac screws. But for sciatic nerve injury, you might have to do a open reduction and a laminectomy, for example, exploration and decompression of the roots of the sacral nerves. And that may, well, you might want to go posteriorly, so a coccolamingomatic and a parasacral midline approach may be more appropriate. You can do it in one stage or two stage, and that will depend a lot on the patient's fitness, the anesthesia time that you are going to do, and your anesthetist, and also the amount of blood loss already incurred after the first stage. The tip now is to review the surgical anatomy and planes. Consider some limited exposure if you can to save blood, and if you are skilled, like the iliosacral screws and minimally invasive 2 incisions, that may help in giving the patient more stability. And finally, you should choose either a prone or supine primary approach. Try not to do a lateral approach like a acetabular fracture, because this distorts and usually find the reduction difficult. So in this case, we did everything from in a 2-stage position in a way. Firstly, the anterior approach, and then the secondary posterior approach for the decompression of the sacrum. Soft tissue injuries. I can't say anything more from a Morel Lavalette than to show you the CT scan with contrast to identify the source of bleed. And also this video that will certainly show you one of the largest Morel Lavalette I've seen. It stretched from the rib cage all the way to the suprapatellar area. And of course, what you see in the early stage is a good skin, but come 1 or 2 weeks later, you will see this necrotic skin, and that will then avoid. If you made incisions in those areas, you would be in trouble with plates exposed. So the surgical algorithm starts with a post-resuscitation. You must have normal hemodynamics, coagulation, negative duplex scan, unless if you do have one, you might want to introduce an IVC filter. No pressure source. So pressure source and pin track infections must be taken care of day to day until you take them out, because often you'll be surprised when you turn the patient over, there's a pressure sore in the sacrum. The main thing to achieve is mechanical stability, and in the rotationally unstable internal or external rotation, or the APC or the LC type versus the vertical stability. In the rotational unstable pelvis, after reduction, is the sacroiliac joint congruent? If it is yes, you may just do a symphysis plating and do a low external fixator or infix, as Puneet has shown earlier. If the sacroiliac joint is incongruent after initial reduction, you have to think of whether it's a sacral fracture, you go on to your sacral fixation. The sacroiliac joint disruption will then go on to your iliosacral screws in most cases. And finally, crescent fracture, you can do either a plate, a screw, or a combination of both. And finally, everything leads to rehabilitation. So all this must bring the patient right through the hospital period. So hopefully in one go and not multiple surgeries. So the basic surgical strategy would be to close the ring as best as possible. All vertical displacement should be corrected to avoid limb length discrepancy and neurovascular traction. Fixation should try to compress fractures. So I am not a good fan of ankle stable plates, so I use compression plates most of the time. And you can do leg interfragmentary screws, usually cortical, not cancellous, and convert plates, whether they are buttress or spring plates. The operative approach should respect soft tissue windows, should allow direct fracture reduction, because it's so complex already. You need to contour the plates, and can be MNS for experienced surgeons like iliosacral screws. And finally, to restore early hip girdle function and avoid all the complications of these bad injuries. Thank you very much.
Dr. Vijay. Dr. Vijay.
Yes, Dr. Manish.
We have 10 minutes now.
Total 10 minutes left.
Yeah. Any other speaker?
Yes, there are 3 more talks.
Okay, please hurry up. I'm trying for extension of time. You carry on with the talk. We'll take questions later on.
Okay. One question you can have, because in the meantime I will load my.
Yeah.
Yeah, Dr. Kong.
Yes. Yes,
Dr.
Vinny.
Kong. Yeah, how are you?
Yes.
Thanks for nice presentation. I just wanted to know one thing. In those patients where you need two approaches simultaneously, would you like to do in a single stage because you need to do the redraping and painting and everything, or do you want to do in the second stage? And if it is two staged, then how much the gap should be there?
It can be another day, 2 stage, but it depends on you and the anesthetist. If the anesthetist says patient is stable, easily without much fluid resuscitation, you did a fairly quick job, anesthesia time is reasonable, then I would do a second stage, especially when I either do supine or prone. Obviously there needs to be redrape. So it's a real teamwork thing, and I think the anesthetist must be as good as you.
I think, Dr. Kong, we can do one thing. We can finish with the talks and then we'll have discussion time, few minutes, because we have 3 more talks to go. My talk is there on the computer now.
Yes, yes. It's there.
Okay, so I will be talking about anterior pelvic ring definitive fixation. So if you look at anterior pelvic ring, it is from the distal end of one hip to the other side, or you can say iliopubic eminence to the symphysis. So what kind of fractures or what kind of disruptions we are going to look at in the anterior pelvic ring is pubic symphysis disruption, pubic ramus fracture, or a combination of these two. So maybe 3 types of injuries we are going to look at. So decision process, operate or not, principles of operative treatment, pre-op planning, already Dr. Kong has told, surgical approaches and techniques of reduction and fixation. So if we look at indications, obviously we are going to operate only unstable fractures, rotationally unstable or maybe completely unstable, vertically as well as horizontally. So if we look at open book injury, so this was 2.5 centimeters, but a single static reading, it has been challenged in now 2 major studies. So now there are 2 studies where they have started using stress radiographs, even if they find 1 centimeter, and there has been switched to operative management in these 2 studies, and studies are done by Sagi et al. And Murphy et al. So I will just show you those studies also. So this has been challenged of 2.5 centimeters. So lateral compression, very few patients, they will need sort of definitive fixation anterior. But yes, there are indications if there's gross deformity of the pelvis. Sometimes in bucket handle tear, there is shortening of the limb. So if there's gross shortening, gross deformity of pelvis, you can say more than 2 centimeters of overlap of rami, or it is like Dr. Abhay told, if you stress it and it is quite unstable in internal rotation. So there are indications, associated vascular injury. So sometimes you have to even fix the rami also. So again, a lot of controversies and a lot of technical controversies here. But 2 indications, the tilt fractures and locked symphysis, obviously we have to operate them to prevent dyspareunia and chronic pain. Type C disruptions, it is all the cases, almost all the cases, they will go for posterior and combined with the anterior internal fixation. Internal fixation definitely is better than external fixation. So if we can do internal fixation, that is always, so it is a wisdom of today, conventional wisdom, to operate on type C pelvic disruptions. So this paper looked at 27% of the cases operatively, they switched to internal fixation. So initially the symphysis disruption was only 1 to 2 centimeters, and when they stressed it, they found it to be more than 2.5 centimeters. So just few radiographs where you would like to do anterior fixation. So this is unstable fracture. Now you can see obviously type C injury, unstable, there is associated acetabular fracture also, which will change the plan. And you can see straddle. And another thing is straddle fractures and contralateral rami fractures and sacral fractures in lateral compression injuries, which are complete fractures. Most of the times you will find anterior sort of crush, but if you find complete fracture, you have to follow it with serial x-rays. There is a study in which there is more than 50% of displacement with minimal loading of these pelvic fractures. So you have to be careful. So another locked symphysis, like this kind of fracture, there is a multiple of there is a dislocation, transverse with posterior wall, and symphyseal disruption posterior. So you have to plan this. So you have to fix the symphysis also in such cases. So principles, posterior ring is important, but goal is to restore the anatomy and enough stability to maintain reduction during healing. So, but there are multiple fractures. You don't have to fix all the fractures. So you have to take it patient-wise. So TO planning, I think Dr. Kong has already told, obviously patient has to become stable, then only patient will undergo surgery. So proper resuscitation is important, proper assistance, blood, ICU backup, and very important is intraoperative imaging. If you don't have a good radiographer, then it's a problem in the operation theater. So you have to train your radiographers, and you have to have a pelvic set, all the reduction clamps, and specialized plates and specialized instrumentation for the pelvis. There is a role of acute stabilization, like Dr. Inder's lecture. If patient is taken up for laparotomy and patient is hemodynamically stable, you have packed and patient becomes stable and there is symphyseal disruption. Another thing is patient is being taken in the theater for urogenital injuries. They have repaired it, and why to apply external fixator there? Why not to do a definitive fixation if the hemodynamics of the patient permits? So there are acute stabilization indications also. Approach is phenol-steel, and if you want to go lateral, obviously you can use extended phenol-steel incision stopa, and low midline exposure. Obviously, whenever you are doing it in emergency situations where laparotomy is also done, you can extend the incision down, and you can get away by fixing the symphyseal disruptions. So in type C disruptions, you will find one side of the rectus already torn. So rectus attaches on anterior side, so you have to superiorly, you have to make a way. And just lateral to pubic tubercle, if you apply a Homan on both the sides, that will aid in reduction of the pubic symphyseal disruption. Like this side, on the right side, it is already avulsed. The rectus on the left side, it is intact. So there is no point sacrificing the rectus. You can get away without damaging the rectus, because if you cut the rectus, then the rehabilitation becomes very difficult. And this is one example of when you go fix the lateral ramus fracture, and you go and fix acetabulum also. So stopa approach. So reduction techniques, close reduction techniques, you just tape both the limbs in internal rotation, or your assistant can apply pressure on both the iliac crest to close the pelvis. Or another thing is by specialized clamps, you can use junk breath clamps or Farabaugh clamps, but you have to make sure, you have to ensure that whenever you put a screw from posterior to anterior, you have to retract the bladder properly. You don't have to injure the bladder. So, and then you can achieve the reduction by closed means and by open means. And now coming on to fixation, type of fixation, we always use 3.5, 4.5. I don't know, somehow our patients, they are not that huge maybe, but Dr. Kong uses always 4.5 mm implant. So it's a debate. So at least 5 to 6 holes. And no screw hole at the symphysis. Number of plates in simple B1 fractures, 1 plates are rotationally unstable. But if you are dealing with C fractures and you are not happy with the fixation with 1 plate, you can always apply a plate anteriorly. But most of the times, a long 5 to 6 hole place is sufficient to give stable fixation. Another good thing is when you stabilize the pelvis anteriorly, whenever you are doing open and percutaneous fixation of pelvis, it's better to do open one first. So if you reduce the pelvis anteriorly, obviously your SI joint will become reduced and you can do a percutaneous fixation. So this is another example of fixation. Now coming on to rami fractures, pubic ramus fractures, which are lateral to pubic tubercle, they usually don't require internal fixation because of the ligament of Cooper, ligament of Poppert, like inguinal ligament, and pectineus muscle. There is no scope of displacement of these rami if they are lateral to the pubic tubercle. But parasymphyseal rami fractures, they should be treated as symphyseal disruptions, and they should be fixed because of very limited soft tissue constraints near the symphysis. So these are the indications. Now this kind of procedure, this is from some other article. So I have never done this, but yes, you can do it percutaneously, because one thing is pubic ramus is not straight, it is curved, so it is very difficult, and a lot of C-arm is being used, and obviously you are doing a percutaneous fixation. Obviously fracture is reduced, then only you will be able to put a percutaneous screw. So in a already reduced fracture, why do you want to take? Because you have to look at risk benefit ratio, and you have to justify your surgery when benefit is going to be more than risk. So pubic ramus fracture fixed in such a way using long screws and already reduced fracture. I think I've never done it, and I'm sure I'm not going to do this. So like this fracture lateral compression injury, you can see the internal rotation. Patient is not able to bring back the limb to neutral. So this is one of the indications of doing external rotation maneuver and fixing the patient. So this kind of simple, this is like 10 years ago when like now we know how to apply external fixator, Dr. Kong, so many courses. So just external fixator on the front to take care of the straddle injury, and this is the union. So with just 3 to 4 weeks of fixator, you can keep the patient rather than trying to put percutaneous screws and using so much of CM and putting the patient of risk of so many injuries. Another case, type C disruption, straddle injuries. We wanted to fix the sacrum. We wanted to do something for the anterior, so single pin fixator for 3-4 weeks and with very good results. So another indication of doing anterior fixation at this kind of injury, you can see, I think already shown by Dr. Abhay, it's a typical tilt fracture. So you cannot treat it conservatively. There are SI joint disruptions. So this is one of the absolute indications of surgery. And so this kind, you can see pubic symphysis. You can see the fractured portion. It is coming out. It was just subcutaneous, lateral. You can see from the slide that the rectus is not detached from any place, and this kind of fixation can be done. Anterior fixation for the ramus and the tilt fracture. So take home, there are a lot of indications in unstable, rotationally unstable as well as vertically unstable patients, and there is a huge amount of advantage of anterior fixation. It is definitely better than external fixation. Approach, fortunately, is Fenton steel and Stopa, and most of the established surgeons, they are familiar with this approach, so it's not a difficult thing. Reduction tips, learn close reduction tips, minimal open reduction tips, and obviously instrument-based reduction tips to close these fractures. And we used 5-hole to 6-hole 3.5 mm pelvic reconstruction plates. The important thing is maximize the length of screws. So if you put a screw just by the side of symphysis and you put it towards the inferior pubic ramus, it is 55, 60. It's a long screw. So maximize the length of screws. That will give very good stability to the construct. Again, second thing we have never used is locking plate for the osteoporotic patients. We prefer to use longer plates, or we prefer to use maybe 2 plates, but locking plate, because it is very difficult sometimes on the lateral side to put the screws through the hole because it's a prefixed direction. But again, Dr. Kong does like in vivo contouring of the plates, and he does that. And obviously posterior instability is the top priority. So you just cannot get away with doing anterior fixation in a type C disruption. So posterior instability has to be taken care of. Thank you.
Dr. Vijay, can you hear me?
Yes, sir.
We have got extension of time. Now it is 9:10, so we have to finish by 9:30. So 20 minutes more.
Okay, right. But we have 2 long talks after this. I think posterior fixation.
Well, we have to shorten it because after 9:30.
No problem. I think we'll go ahead with the next talk. We'll go ahead with the next talk of Dr. Kong, which is very important talk regarding posterior pelvic ring definitive fixation. And we can take the questions afterwards then.
Okay, I'll try to make this fast. Okay, we have gone through some of the anatomy of the posterior ring, but and also Abe has talked about the strong ligaments. The power of the sacroiliac ligament around the back of the sacroiliac joint is the key that holds the whole body up to the lower limb. The ligaments are so strong that in cases where you have a forced external rotation, you can tear them, and when you tear them, these ligaments have lost more than half the strength of the sacroiliac joint to bear weight. But sometimes they fracture, the ligaments hold on to the posterior superior iliac spine and the crest, and you get what we call the crescent fracture. So the crescent fracture is actually a part of the posterior iliac crest that is still attached to the posterior interosseous and sacroiliac ligaments, and the fracture is through the partly through the joint. So this is the difference between a sacroiliac joint disruption and the crescent fracture. There are some dangerous relationships in the posterior ring. The main thing being the lumbosacral trunk that gives you about 2 centimeters of space medial to the sacroiliac joint if you want to put plates. So maybe 2 screws can engage the ala of the sacrum from the first window of the ilioinguinal. If you go posteriorly and you make a cut like this, then of course the superior gluteal artery and the inferior gluteal artery will be at risk. And more important is that they limit the retraction of your gluteus muscle. So make sure your retractor person does not over pull on the gluteal muscle when you try to fix them. The injuries are external rotation. I think that usually results in sacroiliac disruption. Internal rotation is said to cause the crescent fracture, and you can just about see where the fracture beginning to fracture across in this early film, just where the joint is on the ilium and not on the sacrum. And finally, vertical shear fractures also cause crescent fractures. The classification is external rotation, internal rotation, and bilateral. And these cause the sacroiliac joint disruptions and the B-type AO classification, AO-OTA classification. In crescent fracture, there is a different kind of classification, and this is by Day and Martin Berger. And Day classification is 3 types involving respective thirds of the sacroiliac joint. The type 1 is more of an iliac wing fracture, and the type 3 is more of a sacroiliac joint disruption. The classification determines the efficacy of few things. One is the use of external fixator, and certain fractures cannot be held or reduced by external fixator. If you're still using the C-clamp, the C-clamp actually goes right in here, and if you have a crescent fracture, your pin of your C-clamp will go right through to the sacrum. Fracture reduction, again, as I mentioned, is not easy. You almost have to have a direct fracture reduction. And you can do that with either plate or screw. And the surgical approaches I will go through in a while. So for sacroiliac joint disruption, just a case of a patient, young lady, fell from height, hemorrhagic shock, day 1, damage control with the external ring closure with an X-fix. Here we have actually moved the X-fix. Originally was across, and in preparation for the definitive fixation, we just changed the bars above so that we have more space to approach here. After resuscitation of a few days, up to 4 to 5 days, depending on the patient, our plan was to do anterior plating and posterior iliosacral screws. At this point of time, you want to do supine, but always make sure you check the back, the posterior part, to look for sacral source in case you need to go posterior. These are some schematics. If you're doing iliosacral screws, these are the images you get on the wood fluoro in the OT. You have to draw your lines, the anterior body line, and make sure you line up with the promontory line to get a good S1, S2 alignment. The S1 foramen, the S2 foramen must be visualized, and for this, please do bowel preparation. There are very few things in orthopedics that you do bowel preparation. This is one of them. Sacral outline on the lateral is a very important view to take. Make sure your patient is horizontally placed in the table over a bump, and then get your C-arm person, radiographer, to get you a good sacral outline. You must outline the iliac cortical density, and the superior and the sacroiliac joint margins look like that, although you don't really see them. And finally, you decide where to put your screw. So 2 screws can be transarticular, and 2 or 3 screws in the first and second body. And the extra articular screws will be outside the horseshoe of the sacroiliac joint. So in this case, we did a symphysial closure. You can do the Youngbook clamp as Vijay has shown, or you can use a smaller clamps. I find I need bigger clamps rather than smaller clamps. So those little pointed forceps that you get for your towel clips will not do in a symphysial closure. And then you place your definitive fixation, iliosacral screws, and then either plate in front or the rami screws for this tilt fracture we try to preserve the symphysis for delivery purposes in the antenatal or the patient expecting. In crescent fracture, anesthesia is better in the anterior approach of the patient has multiple problems with his breathing. They prefer an anterior supine position. External fixator, as you can see here, usually in place. So putting them prone could be a problem. You have to remove the external fixator. And if you have done already the incisions to do for packing, then of course you use the same exposure to remove the packs and do your fixation. And finally, I find personally sacroiliac joint views are much better seen anteriorly than posteriorly. So reductions are better. You can do this plate technique, a spring plate, where you put one screw in the ala and leave this free. And by using the second screw into the posterior iliac wing, you draw the reduction against the plate, which cannot go any more anterior than the plate. But be careful of anterior exposures. The lumbosacral trunk is within millimeters of your retraction. And I tend to use a Hohmann rather than a Beavers because then the point is always in bone. And always look for reduction. So you may be difficult without C-arm to confirm reduction, and you have to remove this plate and reposition it. If you have to use two plates in the 45 degrees or 60 degrees to each other. So I tend to use one curve and one, or two curve or one curve and one straight. Or you can use piecemeal fixation of the iliac crest with screws and also smaller plates. And then we tend to always try to fix the anterior ring as well, because these are highly unstable constructs. Posterior approach is less common, usually done for the bilateral type 2 and type 3, as you can see here, both fractures. And to do posteriorly, you can attach, you can go for both prior to incisions. You also have a possibility of, you can't see the joint when you're doing this, so you need to have a little finger in the sciatic notch and then feeling the reduction of the sacroiliac joint. Then you can put screws, iliosacral screws, or you can put these plates on the side. As you do such way, you can put a crest along the crest or screws along the buttresses, iliac buttress and the sciatic buttress. Here in this case, the patient was quite stable and we just put large leg screws, 6.5 cancellers. So the take-home message is that crescent fractures actually are more common than pure sacroiliac joint dislocations, except in external rotation pelvic injuries. The fixation should try to compress interfaces. Again, try not to use locking constructs, try to use compression. You can let the interfragmentary screws or use compression plates. The operative approach, you have to study, as I mentioned before. You can do the anterior one like you do here. This is anterior approach, this is anterior approach bilateral, so that you can see the staples, they go right around the bilateral iliac. And then we put additional screws posteriorly by percutaneous screw. Finally, the aim is to restore early sitting. Walking would be the next step, but at least they can sit up in bed and improve their respiratory function. Thank you very much, and please keep safe anywhere you are listening to this talk.
Thank you, Dr. Kong, for such a wonderful presentation. So in the meantime, Dr. Vivek is loading his presentation. We can have one quick question from the panelists. Vivek has already loaded. Okay.
Okay.
Next talk will be by Dr. Vivek Trikha, sacral fractures and spinopelvic fixation. And after that, maybe if time permits, we'll have questions.
Thank you, Vijay. I'll start and try to finish as fast as possible. Sacral fractures in pelvis are usually undiagnosed when you see on an X-ray. Remember, on an X-ray, Dennis said that 51% of sacral fractures can remain undetected. But always, as was told by Abhay also before, think of a ring. It has to break at two places. So if you find anterior ones, look for the posterior injuries. Diagnosis of sacral fractures is done usually by CT scans because you just have a hint of suspicion when you do not see any injury and with wide displacements. And then you look around with the CT scan and you find out whether the fracture is there or not. Thin cut coronal and sagittal cuts will help you to diagnose a sacral fracture. If you look at the Dennis classification, it is based on the fracture, which is how it is placed according to the neural foramina. Zone 1 is lateral to it, which is the most frequent ones. Neurological injuries are infrequent. Remember, they usually involves the L5 nerve root, and when you need to compress them, you might be having some problems with that. In zone 2s are the ones which are through the neural foramina. One of the commonest ones which you find, neurological injuries are there. Bladder dysfunctions are rare in them. And type 3 ones which are medial to it are the ones which are least common. But remember, neurological injuries can be there. And once you are fixing them, you might have some problems with the gallbladder functions as well. And we'll see subsequently how they are further subdivided by Rao committee. Indications for surgery in a sacral fracture is when it is unstable with more than 5 millimeter displacement, either vertical or in a distraction mode. There is a neurological deficit with these displacements, which you want to take care by fixing it, and maybe you might decompress them. And you have got severe axial sagittal misalignments, which happens with the spinopelvic dissociations. The fixation methods are there, which are similar to what we've been looking for the anterior SI joints and anterior of the posterior injuries. The two major ones or three ones with three methods are iliosacral screws, which are used for fixations. You use transiliac platings for such fractures also for sacral fractures. Or you can use sacral plates, which Professor Kong uses many a times. And also, if there is a spinal element also involved, then you do a spinal instrumentations. Remember, once you are reduction, you have to ensure that most of the sacral fractures can be reduced if you have to reduce them from posterior. When there are multiplanar reductions which need to be done, so you need to do them from posterior and from prone position. You try to, let's say that there you see open up and see the sacrum, and if there is fractures are going through the sacral foramina, you try to restore the symmetry of them so that you make sure that the displacements and the compression element is taken care, and also the contour of the neural foramina can be restored back by taking care of the vertical displacements and the mediolateral ones. You can use various distraction and compression techniques by putting in shank pins into the PSIS and trying to compress or decompress them based on the fracture patterns. And then you go about fixing these fractures. So to cut the story short, I'll just show you a few cases. You can see that this is a fracture of a lady who had a fall from height. And you can see these towel clips, which is the standard for the pelvic binder, which is placed in our hospitals. And a urethrogram has been also done. And you can see it has component is of a sacral fracture along with a vertical displacement. She had fallen from 3 stories of metro. And this is what her fracture looked like. There is a zone 1 to 2 fracture of the sacrum along with the anterior fractures. So if you need to reduce the sacrum out here, you need to go posteriorly or prone. And that's what we went about, paramedian incision, or you can have a median incision and then go right up to the PSIS. The incisions and the dissections can be studied from the book. But what you need to do is, as you see, the shank pin has been put into the PSIS, which you can see on this teardrop. We have tried to reduce that fracture, and then K-wires have been put to maintain that fracture in the position. Both anteroposterior, mediolateral, and vertical displacements have been taken care. And then you just put in the screws, as was told by Professor Kong, in both S1 as well as in S2. And you can see that the anterior fixation was also done. And then subsequently, the fixation showed it like this. So this was her AP view, if you see in the beginning. And with the reduction pattern, we were able to bring back the spine, the sacrum, as well as the pubic bones. Outlet views, you can see one in S1, one in S2, the reduction, as well as the anterior fixation, which is a must because the displacements and instability is too high. And this is the inlet view, where you can see that the contouring of the true pelvis has been maintained and has been re-gotten by reduction of the sacrum in both the planes which we want to do. There's another fracture, which is again a vertical fracture, which you can see with the CTs showing type 2 sort of a neural foramina problem. Intraop, again, you go prone. You can see that the displacements are pretty high. You try to reduce them by giving traction, or you open up, you give the PSIS and then try to reduce them. In most of the cases, it will come back reduced. And you can see that it has now the contour of the sacrum is properly maintained. And then I have fixed them with K-wires, and now depending upon the fracture pattern, I can either put an iliosacral screw or a transiliac plating depending upon how good the reduction I've got. And again, the same system, S1 and S2 screws. You can see that one screw in S1 and S2 has been put, and this is the reduction which we have got both in the inlet view as well as in the outlet views. And that's what you go about getting the fixation for such fractures. Which screw to put? Cannulation is easier. Partially threaded, I normally put even in sacral fractures, though they say that fully threaded screws can be put. There is a paper from Jason Lowy from US, which has shown that even if you put in partially threaded screws, you do not agree or aggravate the neural injuries which can happen. How many screws? Depending upon the instability and the displacements, you can see that mostly I put in 2 screws, or sometimes even 3 screws, if depending upon the bulk and the bony bone quality, I can put 2 screws in S1 and 1 screw in S2 if required, as long as possible. Sometimes transsacral screws also are put. Another method is ilial plating or the transiliac plating, which you can do, which makes sure that you are fixing and relying on both the SI joints, which are normal, and then you are fixing them so that the inner sacral fracture can be taken care. Many a times in combination, and especially in Indian situation, when we have places where patients come late to us and we do not have good imaging, it can be used because it is bypassing the fracture site and can act as a tension band also. Sometimes it is used in combination with iliosacrals or transpinopelvic fixation. So a similar fracture pattern with a tilt fracture of the pubis can be fixed by fixing. It was done way long back when I fixed it anteriorly and posteriorly when I was not comfortable. Give 2 paramedian incisions, slide your plate, make sure that it follows the contour of the sacrum as well as the PSIS. I do osteotomies, and then you fix the SI joint from this side to that side, from ilium to ilium, making sure that the sacrum in between it remains stabilized. In type 3 fractures, which was the complex type, Roy Camille, and there are various type of fracture patterns which can be bilateral. And what it does is, it is making your spine element getting totally away from your pelvis. That is where the lumbopelvic fixation comes in. And this is used for gross spinopelvic instabilities, bilateral sacral ala fractures, which are H-type or U-type fractures. And also if your instability is going through the Eisler's classification, type 2 and type 3, which are going medial to or through the S1, L5, S1 facet joint, which means that your instability has gone into the spine, then you require the lumbopelvic fixations. It helps us to give a very good stability. It can resist all sorts of displacements in vertical, angulation wise and translation wise. In all the 3 planes, it can resist. It allows early mobilization, and the next day you can make the patient sit and weight bear also sometimes without the need of external braces if your fixation is good enough. Just show you one of the spinopelvic dissociations or the flexion flight of fractures which can happen. There's a bilateral fracture of the sacrum ala, you can see, as well as you can see that there is a jumping of the S2, S3 type. And those fractures which can be reduced and can be fixed are done through spinopelvic fixation. Here you can see L4 and L5 pedicular screws are put, and then you bypass the S1 and go into the S2 long iliosacral screws, which long sacroiliac screws which can be put. And then you can have even screws which are going, making it as a triangular fixation which can be done. So that's what you go in and you do the fixation, provided there is the instability of the sacrum is now extending into the lumbar spine as well. And this is what that fracture and the pattern looks like. It is so stable a fracture fixation that you can even make the patient mobilize the very next day if you want. And that's his follow-up. If I look at the sacral fractures and their associated injuries, there is a huge review article from AO Spine, which says that regarding the neurological injuries, most of them improve with time independent of the choice of treatment. So this question comes many a times in sacral fractures with neurological injury, whether we need to decompress or not. This is the Spine global admissions and the suggestions by Vaccaro and other colleagues who have shown what is to be done. Posterior sacral laminectomy can provide a best chance for neurological recovery, provided there is a huge compressive bony element which you want to reduce it. However, still there is no high-level study which directly compares a laminectomy to indirect decompressions by distraction methods and shows that which one is better. So the jury is still out regarding the neurological damage in the sacral fractures, whether you should be decompressing or not. And this is the thing which is there in review articles from the Spine. So I'll finish by saying that sacral fractures are difficult injuries. I've just tried to give you an overview in the last 8 to 10 minutes. Various modalities of treatment exist. The most 3 common ones are that iliosacral ones, the ilial platings form the mainstay. If there is a pelvic and a spinal instability, then you need to do a lumbopelvic fixation also, which is required in special cases. However, the thing remains the same. Do no further harm to the patient and make sure that you are preventing complications while treating these fractures. Thank you.
Dr. Vijay,
Manish, can we have questions or we are quite late?
No, Dr. Vijay, I've taken 10 minutes more. So we have time for questions.
Okay, so questions from the panel, from the other faculty, any comments or questions?
Can I ask Dr. Trikha, do you use traction tables or things like star frame, etc.? Do you have any experience in that?
No, in India, we have got a lot of junior residents and residents with us, with a trauma fellow, also with a pelviacetabular fellow with us. The problem with these is that we do not have the Adam Star frames available with us, and that we are not very conversant with. That's why we are not using. But I feel that most of the sacral fractures, by doing these distraction and the traction methods, we are able to get them back. If required, we just sometimes do a distraction by stabilizing with the pelvis in the pedicular screw and the PSIS, and are able to take even 90 days and 100 days old vertical displacements of sacral pelvis.
Okay.
I have one question.
Dr. Kong.
Yeah, Dr. Kong wants to
Yes.
ask.
One thing about pelvic sacral fractures is that they bleed a lot. So I tend to go in after 7 to 10 days. If the neurological deficit is more of a neuropraxic suspicion for neuropraxic pattern, because they are all root injuries, so the timing is not so critical. You seldom get a CSF leak, for example. So, but they do bleed a lot, and you can have a patient on anesthetic hypotension, and they still ooze anywhere you play around with the pelvis. So be careful about going in too early.
Any other question?
Puneet has a question.
Unmute. Space bar.
Yeah, Dr. Vivek. A very nice talk on sacral fractures. I will just have a question here. If you have a vertically unstable sacral fractures with both anterior injury as well, so is it better to fix the anterior injury first and then make the patient prone, or go prone first and then make the patient
that dilemma will always remain when you are doing it from prone or anterior ones. It never will go away, but it will depend on what sort of fracture I've got in the interior part. If it is a symphysial diastasis, I might go anterior first and then go about taking care of one hinge in the interior part first, and then taking care of the posterior one, where I'll have to take care of only one plane of displacement. Exactly. However, if it is of a pubic rami fracture, which is comminuted out there with a vertical sort of a Morgagni, sort of a bilateral straddle fracture or something like that, I might prefer to go posteriorly, reduce it properly first, and then based on my posterior fixation, I'll go about taking care and changing, or you can say slightly modifying my anterior fixations.
Yeah, the why
depends upon the, I think,
anterior in the presence of anterior instability. If you try to do prone first, do the reduction maneuvers, open reduction maneuvers become more difficult. Do you think so?
Yes, they do, because the multiplanar fixation which you require sometimes is lost. But I would try to go I would not like to get a malunion at the symphysial pubis right in the pubic rami right in the beginning, so that my good reduction of the posterior ones with the neural part is hampered in any way. So if it is a easy case for an anterior fixation first, I'll go there. Otherwise, most of the cases I go first in the posterior part, get my good fixation, depending upon the stability and the reduction which I get, then I subsequently can alter my anterior fixation, sometimes conservative, sometimes screws, or if I feel that I require good fixation on the anterior part, I'll even go in with the intrapelvic plates for that.
Right, thank you.
Okay, I have a question to Dr. Vivek. Hello.
Yes.
Yeah, like Vivek, type 1, type 2, obviously you can get away with putting sort of screws, sort of SI joint screws, long screws. So what is your experience in type 3 fractures? You always go prone and fix it with plates or some sort of something prone, or you can get away with the long screws also from supine position?
If it is in a sacral fracture, you're talking of Dennis 3 fractures, right?
Yeah, Dennis 3.
So if it is a central fracture, it depends upon the displacements actually. For me, I'm not a very good or very big proponent of lumbopelvic fixations in true sense. I still feel Euler classification type 2 is not the right fixation, is that you go in and fix in lumbopelvic, spoil the two pelvis pedicular facet joints of a mobile lumbar L4 and L5 and then fix it. I invariably in those cases also try to see whether the combination is too big or not, which is going to hamper my transiliac screws. I try to put in my transsacral screws in most of the fractures, be it S1 is Dennis 1, Dennis 2 or Dennis 3. I put in both transsacral in S1 and S2 usually, and that is forming the mainstay. However, if the combination and the displacement reduction which I get is not that best or anatomical for me with this, where I can damage some further neurological damage, then only in type 3 Dennis along with the Isler's type 3, I might go in for a lumbopelvic. I reluctantly go for lumbopelvic only when the stability of the spine is too grossly unstable, not at the drop of hat, just like what the classification says and what in Indian setting what we do is slightly different. That's what I feel. And we go about without I do not have any big series to show that I have got failures when I'm fixing with transiliac screws rather than going in for a lumbopelvic.
Dr. Vijay, there is final question from Dr. Kong, and I think then we should finish it off. Dr. Kong, he has raised hand. Dr. Kong.
Unmute.
Unmute.
Space bar.
I forgot to lower my hand, so I lower my hand now. Vivek has answered it because I too don't do lumbopelvic fixation unless they are the jumpers type H and U pattern, usually bilateral. But on the one side, 2 trees, again screw, we use what we call the M plate. It looks at the back of the lamina of the sacrum, and we find they can have 6 screws in the sacrum and the iliac wing. And we use this galving plate, which we designed before.
So when you're doing the lumbopelvic fixation, are you looking at taking the lumbopelvic fixation off also?
Yes.
Yes. So that's
but again, by the time you remove it, which is 6 months to 12 months, and you have gone through the facet, you have already destroyed those facet joints of L4 and L5, and you have fused them. So the lumbar sign, 40% of your mobile lumbar's vertebrae, 40% has been made immobile, because an ideal spinopelvic requires screws in L4, L5, and then iliosacral. So that's why I'm not very keen unless it's really, really essential.
So
Dr. Vijay.
Specific indication.
Yes, Dr. Manish.
Sir, we have to wrap up now because we have only
Okay, Dr. Manish, over to you. I think
because I think if the discussion is going on, we can go for 1 or 2 hours more because there are 1,700 people logged in. After 17 webinars were there, today was the highest number of webinars, 17 webinars of orthopedics. So we are the last one. We are the last one.
That's a great achievement.
Okay, I'll
great achievement. And
yeah, and I have to first mention that I really thank my technical team, Dr. Ravi Chauhan and Dr. Shamsul Huda especially, from the Ortho TV. And Dr. Shamshul, are you online?
Yes, sir.
And he is a great person. He has provided the whole technical support. And I request Dr. Shamshul to speak something about yourself and the Ortho TV.
So thank you, sir. Good evening, sir. I'm Dr. Shamsul Huda from Patna, practicing orthopedic surgeon and iliac surgeon. I'm coordinating all these webinars on behalf of Ortho TV and Dr. Ashok Shyam, sir. Thank you, sir.
And really thankful to you, Shamshul, for organizing this, great webinar. And I also thank Dr. Vijay Sharma, who has done a marvelous job in arranging the faculty and selecting the topics, and all the faculty, and even our foreign faculty from Singapore, from England. I really thank you with my folded hands that it was a great, great, great success. I request Dr. Hitesh Lal, Secretary of DOA, Delhi Orthopaedic Association, to give his closing remark. Dr. Hitesh, I think Hitesh has left. So, Dr. Sharad, are you online?
He's there.
He's there.
I am here.
Yeah, he's there.
Hitesh is there.
Yeah.
Hitesh, yeah.
I think this is the third or the fourth course of Dr. Vijay Sharma. This is a landmark course designed by him. And all the faculty was very nice enough, and we are grateful to them who have joined this course. And it was a really nice hearing to you all. And I think the 1700 people have logged in. It was a great course.
Dr. Harmesh, any final closing words from you?
Unmute, Harmesh. Harmesh, you have...
Dr. Harmesh.
Dr. Harmesh is not there. Yeah, he's there. Sir. I have unmuted him.
No, he's still there.
He's still there, yeah.
Yeah. Thank you, Dr. Manish and Dr. Shamsul, all for your technical support. And Dr. Vijay, it's always a pleasure. So, last year it was a lot of fun physically being present there. But anyhow, this was a great course. I really find it very useful. Thank you.
So I thank everyone, and we'll go on now. Yeah.
Okay.
That is a very difficult subject. And thanks to Dr. Vijay and your eminent faculty that you have given a systematic approach to this difficult problem. Thank you.
Sir, see, the course is so successful that this is the 17th webinar. Like all the webinars have been done, this was the last webinar. And 1700 people, if they are sitting and hearing this thing. So it's a great success. And that credit goes to Dr. Vijay Sharma and you, sir. Okay, sir. Thank you very much.
Credit goes to all faculty, all panelists, and everyone who was involved in the webinar. Thank you.
Sir, 14,000 audience for the day, sir.
Yeah. Okay.
Thank you, Shamsul. Thank you.
Good night. Shamsul will be offline now.
Good night, everybody.
Good night.
Good night, Dr. Kong. Good night.
Good night, Vijay. Thank you.
Vijay, we
Good
still
night,
have
Inder.
the
Good night.
established to cover.